seeing how in India we are performing rather than just, looking at the data from other countries. It's very exciting to see that you show a lot of positive effects of PGT in a number of instances versus not. Something that I wanted to ask you was that in one of your slides, you indicated improvement in time to pregnancy. Would you consider PGT just by itself as an improvement in TTP, or in only in selected cases do you suggest that we should use PGT for improving time to pregnancy?
So can you just repeat the question? The voice is not very clear for me.
Yes, I think I'll mute everybody other than the speakers. So I need to mute a lot of them. Kindly mute yourself.
Yeah, Dr. Shirin, the question is, you in one of your slides, you indicated that with PGTA, you could reduce the time to pregnancy by nearly half. I think it was in advanced maternal age group.
Yes, sir, in advanced maternal age.
So in other groups, do you think PGTA still can reduce time to pregnancy, or you think it was not analyzed, or you don't think it is important?
So for now, we have analyzed only in advanced maternal age, but in rest of the groups, we could see an improved, in few groups, we could see an improved live birth rate, and in few groups, it's not helping much. And the time to get pregnant, we only analyzed in advanced maternal age. Rest all groups, we didn't see the time to get pregnant. Hello, sir. Am I clear with the answer or? Hello. Am I audible?
Yeah, Dr. Sayali, you have to unmute yourself.
Yeah, you're so Sharon, I think he went offline. I don't see him. So we will have to join back. Please mute yourself. Dr. Sorry. Yeah. So Sharon, I was saying that he's not online. So I think that we will have to wait until he gets back. Meanwhile,
Dr. Deepak is back. Yes, Deepak is back.
Yes, sorry, my electricity had some issue and everything just shut down.
Yes.
Sorry, I think we can go ahead with the presentations. I think Dr. Sheetal had some question.
Yeah, so I think I joined in between the lecture, but I had a question for Dr. Sharon.
Yes,
so I just wanted to ask you, can you just explain me how PGTA helps in reduction of time to pregnancy with respect to advanced maternal age?
Ma'am, we have seen the time to get pregnant only in advanced maternal age. So we have observed. Hello.
Yeah.
Yeah.
Yeah, I can hear you, please.
Yeah, so in advanced maternal age, so almost 60% of patients got pregnant within the first transfer itself. And when PGTA was not offered, they took, I guess, around 2 to 3 cycles to get pregnant.
So was the PGT the only reason that the patients who did not conceive with advanced maternal age, do you want to say that in those patients who did not get pregnant in spite of doing, was PGT the only positive factor which helped in their conception, or was it something else? Don't you think this is, there is a bias, if we look at it like this?
Yeah, ma'am, there could be a bias because it's a retrospective data, and so we couldn't control all the confounding factors there. So I would say, yeah, there might be a bias. So right now we have seen only PGTA as an intervention. So
okay,
we can look into it more.
Yeah. Okay. Thank you.
Thank you, ma'am.
Anyone else has a question?
Yeah.
Hi, Dr.
Shereen.
Hi.
Hi, I'm Dr. Naushin from Craft. It was quite an insightful presentation. My question is, you compared data between day 5 blast versus day 6 blast, right?
Yeah, yes.
So you transferred the day 6 blastocyst after 6 days of progesterone or after 7 days of progesterone?
After 6 days of progesterone.
Okay, so you basically treated the blast like a day 5 blast.
Yeah, day
right?
5 blast only. Yeah.
Okay. Because the reason why I was specifically asking was there was an article by this Rollins and all in Fertility, which said that the miscarriage rate can be reduced if you're transferring the slowly developing day 5 blast, which is basically day 6 blast,
Okay.
on 7 days of progesterone rather than 6 days. So I just want to clarify that part.
Okay,
Now,
here we have done progesterone only for 6 days. No, we
6
didn't
days.
extend for
Okay.
7 days.
Okay.
Okay.
Now, one more question which I had was, what is the justification for no improvement in pregnancy rate in double embryo transfer in advanced maternal age or young age, for that matter, when you compare with that of elective single embryo transfer in non-PGTA cycle?
So it doesn't say that with double embryo transfer, it too is comparable. Both when we are transferring elective double embryo transfer and elective single embryo transfer, the outcome was comparable. So we would say that there is no, we
So
won't recommend.
was there any difference in the pregnancy rate, or there was no difference at all?
There
Because
was
you know
not
the
much
slide was
difference.
quickly moving, so I couldn't capture the data well.
I'll just. Is my screen still shared?
Yeah, the screen can be still seen.
Okay, yeah, here you can see that the pregnancy rate, it's almost similar in both the groups when we are transferring either elective single embryo transfer or elective double embryo transfer. The pregnancy rate or the implantation rate, everything seems to be similar. So it doesn't
This
help
is
much.
non-PGTA cycle or PGTA cycle?
It's all PGTA.
Sorry, non-PGTA.
It's all PGTA. PGTA. That is elective double embryo transfer and elective single embryo transfer. So it's euploid double embryo transfer and euploid single embryo transfer we have done.
Dr. Naushin,
Okay, I assume that
Dr.
it is
here. I think we'll have to.
Dr. Sayali.
Hi, how are
Yes.
you? So only request if we can just put in the questions because there are we kind of
Right.
move
It
on.
got clear. It got
Yes,
clear.
sure.
Yeah.
Okay, but we would love to take all the questions. Any questions that you have, anybody that has questions, we would strongly suggest that you either put it in the chat. We will try to copy the chat and put your emails on it so that we can respond to the queries in due time, because it would be difficult to address all the queries with this humongous amount of data at one point of time. So well, definitely, if you have any questions, we would be looking at them. Thank you. Yeah. So, Ms. Sherin?
Yeah.
Dr. Sherin?
Yeah, ma'am.
Yes. So, I think we can take questions later. Thank you so much for this presentation. Although I also have a lot of questions, I did not want to take the time of the audience, because we will be evaluating all this data and we'll be coming back to you. We are thankful to you for sharing all this data, and thankful to Dr. Krishna and the OSS team that they have provided this data so that it helps us create better guidelines from Indian data rather than depending on any other data that comes from outside the country. So thank you very much.
Thank you, ma'am. Thank you, ma'am. Can I stop sharing?
Yes.
Yeah.
And I would like to take this opportunity again. Please mute yourself, all of you. Okay, that was quick. Thank you. So, all right. So I would like to request Dr. Fiona to take over for the next introduction, and then we can begin.
Hello, everyone. Good evening. It is my pleasure to introduce our next speaker for the day, Dr. Sayali Kandari. Very experienced person, as we all know, PhD in biology, at Center of Biotech and Research Center, and she's also the scientific director at Aneuploidy. And she's also a laboratory director at multiple locations in and out of India. And she would be talking to us today on embryo biopsy and embryology KPIs for PGT-A. Over to you, Dr. Sayali.
Thank you so much. Sorry, I'm facing some issues. Thank you so much for that. I wanted to not introduce myself. So thank you, Fiona. You're a dear friend, and thank you so much for that presentation. Thank you so much for that introduction. I'll be sharing very quickly. I'll be sharing the screen. Am I audible and is my screen visible?
Yes.
Yes.
Okay, all right. So taking over from the last lecture where Dr. Sharin shared that lovely entirety of data that comes that is coming out from a very senior center and a lot of IVF cycles, we now move on to the next topic that hasn't been spoken about much. The first thing that we did when the consensus guidelines were created was that we wanted to jot down from the embryology side of things, what exactly are the parameters that we need to be looking at, and what kind of pan-India guidelines for KPIs or key performance indicators are available and can be mapped for PGT-A specifically. All right, so quick overview. This is how, from that procedure that happened in 1978, and the first IVF baby was born in the world and the second was born in India. We have come to this stage in 2023 where we have a complicated ART process. We not only have the clinical side, we have the embryology side. We are looking at quality, we are looking at parameters. We have multiple softwares or multiple inputs from which we'll be able to evaluate and analyze the entire data. And now is the opportunity for us to really map down that what are the parameters and what are the practical considerations that we should be doing when we are doing embryology, as well as putting in pre-implantation genetic testing, aneuploidy in any IVF center. So this slide has been, and this data has been taken from the embryology consensus guidelines that were the first in the country that were prepared during ISAR. And what was nice about it is that it started with the template that Eshe had provided, and it tried to grave what are the basic requirements, infrastructure, personnel, and otherwise that are required for doing PGT, and what all you require in embryology in terms of the equipments, in terms of the technical expertise, and in terms of how many cells you should be taking out. All the basics were covered in this. This is an opportunity to move on and implement a better guideline, looking at even the details of what kind of KPIs now we can map, particularly for more laser focused things like PGT-A. So today, what happens in a PGT-enabled ART lab? So we have an ART lab that can do PGT, then we have an ART lab that can do PGT. So it looks very simple that, okay, if you want to do PGT, just call somebody who is a biopsy operator and you'll be able to conduct the procedure. You can rent a laser and you are good to go. But the truth is that before you implement PGT, you need to monitor your performance indices, not just KPIs, but also the others. Also the other indices that are required before PGT can even be implemented in the laboratory. And when you even before you start your first PGT cycle, you need to be aware of what are the parameters that your embryologist or your biopsy operator needs to know technically that he needs to map out or pull out at the end of the month or at the end of the PGT-A cycles. Now, PGT-A is the most terminal and technically advanced procedure that needs to be monitored on a continuous basis. What are the workflow performance indexes that we have to look at? So the procedural ones are, for example, what is the timing that the operator requires per biopsy, which is directly correlated to the health of the blastocyst after you do the biopsy. Because as we know, the more the exposure, the more the problems. The other technical indices are, after you do tubing for every biopsy, what is the DNA amplification rate you're getting? Whether you're getting conclusive analysis in 90% of the cases or higher, or 95% of the cases or higher. So what's your benchmarking? What's your competency level? And what's your benchmarking level? The embryology parameters. So embryology KPIs are now, we are into a decade of knowing what embryology KPIs are. However, we are still lagging behind in monitoring them. We are still lagging behind in implementing a proper QI protocol, which is quality improvement protocol, using them. However, the basic minimum that you need to know is what is the survival post-warming of biopsied blastocysts and what is the re-expansion. We'll be looking into this a little bit in detail. The clinical performance indices. So we all know that the reason PGT-A is offered is very different than the reason why PGT-M is offered. PGT-M is something like is something of a requirement for the patient because they have a genetic disorder they need to screen out for. But PGT-A is offered because we want to reduce the time to pregnancy. We want to improve the live birth rate per patient for every embryo which is transferred back to the patient. So we are trying to increase the efficiency of IVF. It's basically an efficiency improvement protocol using PGT-A. So the outcome parameters that we need to look at is live birth rate per PGT or live birth rate per patient. So now to begin with, what are the basic laboratory KPIs that you need for QMS, which also map the biopsy process? So as we know, these are all from the Vienna consensus. I have put them down because they are all required for you to map the competency level of your IVF laboratory. Once you have the competency level of your IVF laboratory, then you can begin thinking of implementing PGT-A in your laboratory. As you can see from the left side column, these are mainly ICSI performance indices. On the right side, you see development rate, day 3 to day 5, which is very important because you need a lab that has excellent blastocyst rates. And when I mean by excellent, I mean benchmark blastocyst rates, above 60% is what the Vienna consensus is telling us to have. A successful biopsy rate. And what do you mean by successful biopsy rate? Successful biopsy rate means you have a positive DNA amplification result. So the minimum value is 90% and your benchmark value is 95%. The blastocyst cryosurvival rate. Now, this is different for biopsied as well as non-biopsied, but they have to be similar. In case you have a lot of variation between both, there is definitely an improvement required, a QI required in that stage. Let's move on, get into a little bit more details of what KPIs are required for biopsy. Like I said, the blastocyst development rate would be top. Successful biopsy rate, again, from the Vienna consensus, and the blastocyst cryosurvival rate, which has to be 90% at competence and 99% at benchmark. Now, again, when we have the Vienna consensus as a background, this is not from Indian data. So we need to also start collecting data from the Indian continent, although that is a good skeleton to begin with. Now, one of the things that I have put this, what is the different KPI for biopsy protocol, is to tell you that when you're looking for results or when you're mapping the processes in your laboratory, the way you do the biopsy also matters. So for example, I'll be just sharing why the difference comes and how you need to be mapping the data. In this particular paper, they have mapped 2 different biopsy protocols where they have day 3 pre-hatching. They hatch the day 3 embryo on that particular day. They allow it to herniate on day 5 and day 6. And this herniating mass is biopsy using the pull method. In the other protocol, you have direct day 5, day 6 trophectoderm biopsy, in which you make a hole on day 5 or day 6, and it is called sequential hatching and biopsy. And you use the pull technique to take out sufficient cells, and you either flick it or you put laser shots on it to ensure a biopsy. Now here, this particular paper had more than 1,600 embryos divided in 2 different protocols. And there were glaring differences in the kind of live birth rates they got, in the kind of ongoing implantation rates they had. So the number of biopsied embryos were much higher when there was sequential blastocyst hatching, which was done directly on day 5 or day 6. They had far higher survival rate compared to 95%. They had 99. Here, I'm only looking at the parameters that have a significant p-value. Clinical pregnancy rate was almost 10% higher, and live birth rate was also almost 12% higher. So you have to be really, really careful when you're mapping KPIs, that although that the live birth rate with a regular IVF cycle or ICSI cycle might be similar with PGT, you might be causing some harm dependent on what biopsy methods you are using. So it's very important to keep comparing methods and keep comparing biopsy operators in your particular setup. Then the other KPIs, the other PIs are vitrification. That's the next step and a very crucial step after biopsy, where a lot of parameters change. So some of the parameters, in fact, this is an exhaustive list of parameters that I have gotten from 4 papers, which is what are the post-biopsy performance indices. So for example, if you can see, there is a classification of whether your blastocyst was hatching or hatched. 1, post-biopsy time of culture. How much time do you give the blastocyst post-biopsy in culture? And your results will depend on how long you keep them in culture. Again, I'm not giving any recommendations. I'm telling you these are the KPIs that have to be mapped. Post-biopsy re-expansion classification. You need to classify according to the current publication. So this is a useful publication paper that says that you have collapsed blastocysts, you have semi-re-expanded, you have fully re-expanded. Vitrification protocol and timing. There is one paper that looks at how hatched blastocysts need a lower time of equilibration versus blastocysts that are fully expanded. And hence, if you're using different protocol and timings, you need to map the KPIs for each different procedure. What is the status of the blastocyst that was done post-biopsy, not pre-biopsy? Pre-biopsy status would be definitely different than post-biopsy. Post-biopsy, you will always have either hatching or hatched blastocysts, but these are artificially hatched. So you have to note that down accordingly. The re-expansion of a hatched blastocyst, which has naturally hatched versus a biopsy blastocyst, will be different. And it has seen that the biopsy blastocysts re-expand much faster than those naturally. Re-expansion post-warming and the timing of ET. Again, 2 parameters, 2 KPIs that you need to map. How long did you keep it in culture for re-expansion, and what was your timing of ET? What was their method of ET, and which was the media used? Because there are different types of media. You have hyaluronan enriched media. Sometimes you have high protein media that are used for biopsy cases. So that is also a difference that matters in terms of implantation. How many number of euploid blasts you transferred? We had this question. Why was there no difference between 2 euploid blast transfer versus 1 euploid blast transfer? And then again, you need to know how many euploid blasts you transferred, whether there was any mosaic that was transferred alongside, or whether there was any untested blastocyst that was offered alongside. Thank you. Thank you very much. If you have any questions, this is one of our emails. You can send all the questions here from all the lectures.
Dr. Ritu, you are not audible still.
I think there's some issue with her.
Now you're audible. No, she's not.
Yeah, no, it's me.
Sayali, that was a wonderful talk, and I think you have opened the Pandora's box now. That on one hand, we need KPIs for IVF labs, but now we want KPIs for even PGTA, which we have been discussing as IFS SIG applied genetics for a long time. That are there any key performance indicators for PGTA? And I think it's high time that we define them. I really liked your idea of the list which you had put up, that we need to have comparable post-thawing rates, comparable clinical pregnancy rates, but I mean the live birth rates. I was curious whether, as a guideline, would you want to have a comparable clinical pregnancy rate or comparable live birth rate, considering that many clinics who are offering IVF may not be directly associated with, may not have the complete outcome of all the patients that they have.
Absolutely, and I think we would probably have to terminate the data collection at clinical pregnancy rate for many centers, although it would be very useful to have live birth rates from centers who do the entire till pregnancy and till birth part of it. We actually also have a statistician on board that we work with to evaluate data, and what we have basically said is, instead of having, standard RCTs, definitely the retrospective real world evidence data can be collated and looked at. And we can have different statistical model that looks at the entirety of the data with CPR and sub data with LBR. And maybe that could help us. Also, Dr. Deepak, like you said, the problem currently is standardization of PGT in India. PGTA is not standardized, and through my consultancy, we have been trying to bring in standardization. We've been trying to bring in QMS, and that's definitely one area of challenge, that IVF procedures, embryology, and PGTA or PGTM, any kind of PGT, the standardization does not exist. So it's best to collect the data of what you really do in practice, so that if we have 10 subgroups, then we have 10 subgroups, at least in the beginning. Yeah.
Absolutely. I think that makes a lot of sense. And there's a clear message here, everyone who is on there, that if you are performing PGTA cycles, please do a good record keeping and please share your data, either in terms of in forms of publications, or me or Sayali will be more than happy to help you analyze it, so that we have this data and therefore we could have more better data for this country, and then we can make more better practical guidelines rather than just some random documents which keep happening otherwise. Also, I was wondering that one of the KPIs you did say was DNA amplification rates.
Yeah.
Post biopsy.
Dr. Deepak?
Now, this is going to heavily depend on the lab that's been performing it. Am I audible?
Yes.
Echo is coming. Echo is coming.
Okay, can you hear me now?
Yes, yes.
Yes.
Yes, Dr.
Okay.
Deepak, now you're audible.
Yes. Yeah. So when we are talking of DNA amplification rates, that will also depend, like Fiona would also agree with me that, even the laboratories, different labs have different DNA amplification rates. So, now keeping that as a KPI for the embryologist or the IVF lab doing PGTA, how advisable would it be?
No, so basically that's not an embryology KPI. If we go back to the slide that says there are 4 different types of PIs, performance indices, this would be a technical PI, a technical performance index. So the technical performance index includes the entirety of the process from the lab to the PGT lab, from the embryology to the PGT lab, and eventually the collective efficiency of doing DNA amplification. So that is why working with just a couple of labs is advised, because the more you divide the data between multiple labs, the more difficulty you're going to have in analyzing whether your process is working. So the embryology KPIs is something that we can monitor within the embryology laboratory, but DNA amplification is something that has to be a joint result or a joint KPI of the PGT lab plus the embryology lab. So lab A plus lab B and equal to the efficiency PI, which would be the DNA amplification rate.
Okay. Anybody has questions? I'm sorry I took over the stage of. I take this liberty every time.
you do.
Dr. Sayali, what about this mosaic embryos? A lot of discussion is on mosaicism.
Oh my God, the question you asked.
Which we all dread every time.
The threat of getting
because it's a dilemma.
It's absolutely a dilemma, and I am so glad to say that we have geneticists that is for presenting next. And in terms of mosaic, I want to keep my comments very crisp, because I want Dr. Fiona to present how to select the PGT lab. Mosaicism can be dependent on the embryology laboratory. Because aneuploidy as well as mosaicism is potentially quite possible if the culture system is not optimized. Number 2, if the mosaic level reaches above 5%, which is normally the competency value that we have seen in multiple consensus, including PGDIS, although we do not have any consensus on Indian data. If it is exceeding 5% for either the combined KPI of the PGT lab and embryology, or either for the embryology. So if the embryology lab is giving the biopsies to say 2 labs, and both
Okay.
labs are giving you mosaics of 10%, 15%, that means the embryology lab is probably more at an issue. They need to be troubleshooted. If it's just one PGT lab giving you mosaicism above 10% and the other one is giving you below 5%, then definitely you need to see that the lab B needs to be troubleshooted more. In terms of the classification, whether we should transfer the mosaic or not, that's a completely different discussion, because again, that mosaic data does not come from India. But even though it does not, whatever worldwide data we have on mosaic, it still says, like, for example, I can give an example of Dr. Fiona. When they gave a result, and correct me if I am wrong, Fiona, when they give a result, they give a result of euploid and not euploid. And a mosaicism of below a certain percentage is considered euploid.
Yes, we do have a cutoff which ranges from 20% to 80%. Anything below 20% is categorized as euploid. Anything above 80% mosaicism is considered as aneuploidy. And everything in between is reported as mosaic, and you will get the percentage of mosaicism per embryo, per chromosome, and then you would be able to take a call. If it falls below 50% level, it is considered now transferable and has a very good pregnancy outcome and implantation potential ranging up to 85%. In case it is a high level mosaic above 50%, it is in the absence of other euploid embryos, we can choose to transfer them, though they have slightly lower pregnancy rates, about 45% or so.
Yeah.
This is what literature says.
So there's from my perspective, there's more. What I think is, before you start, of course, you have to follow the recommendations of the genetic lab. Before that, you even need to look at whether these mosaics are coming from the idiopathic, whether we are creating mosaics in the laboratory by not having optimized culture systems, because there has been a huge RCT looking at that, and there have been definitely more mosaics in labs that don't have optimized culture systems. But if you do have mosaics less than 5%, then definitely what Dr. Fiona is saying, and even if you have higher level of mosaics, that applies. The PGDIS guidelines currently apply. We are still deliberating quite a lot, and that is the huge controversy, because there have been we have been doing this since 4 meetings, right, Dr. Deepak? There's been 4 meetings. We have been, and every time the question of mosaics comes up, we have more questions than we have answers. So we are definitely noting everybody's questions down. And for mosaicism, we need more data from the Indian subcontinent to actually give a guideline that is representative of India.
Next,
Yes,
one more
absolutely.
question: whether karyotyping of both partners and Y chromosome microdeletion testing is required before doing PGTA? That's
Yes, and I think Dr. Yes, please.
yes, all
Definitely
things are
required.
required.
Definitely required. But Dr. Deepak, please, for Y chromosome microdeletion test, because the ICMR has developed a kit for the
Yes,
Indian.
so definitely, I would recommend that irrespective of the PGTA cycle or not, all IVF couples must undergo a karyotype and Y chromosome microdeletion, because if they have a karyotypic abnormality, they straight qualify for PGT SR. You don't really need to even go through many changes. I mean, you don't need to do a lot of pre-treatment workups or anything. They straight go for IVF, the PGT SR cycles, and there have been clean evidences that the pregnancy rates really go up in couples with karyotypic abnormalities and Y chromosome microdeletions if PGTA or PGT-SR is combined.
That is for
Dr. Deepak,
translocations. Huh?
That is for karyotypic. Yes, that is for transportation.
Dr. Sheetan, you had a question.
Sorry.
Yeah, no, I don't have a question. I just wanted to add and ask again. We don't need Y microdeletion for every patient going for PGTA or SR. So it would totally depend upon the workup. Yeah, that's all.
So if it's a male factor infertility, severe oligospermia or azoospermia, Y chromosome microdeletion is recommended. I almost assumed that was. Yeah, thanks for correcting me. Definitely. Yeah. And I'm really glad to see at least 2 of the top labs that we have ever discussed who have shared their real life data. Both of the labs have shown that less than 5% mosaicism rates, even in our country. 3% today, and even Dr. Deepak was almost at the same numbers. So that's exciting that we don't have I mean, sometimes I really wonder that the amount of discussion that we do in mosaics is more than the number of mosaics that we ever
I
Right,
encounter.
absolutely. I totally agree to
I
it.
agree
Totally
because
agree. Yeah.
I mean,
in
to a naive
so many
person, it might
years,
appear कि बाबा सारे embryos ही mosaic निकल आएंगे मैं क्या करूंगा, but I don't think that's the case.
That
So
that
if-
doesn't happen actually.
but if
Even
if it is happening for any centers, especially if they are just starting PGTA or they're not, optimized in terms of doing PGTA, there is quite a possibility that it can happen. And then, they shouldn't feel that they can't seek help in terms of reducing mosaics. And so that's why, we offer our help that if you do have higher rates of mosaics for some reason or the other, coming from any source, could be PGT lab or could be any issue with transportation, could be any multifactorial things that happen. You could definitely do a root cause analysis in RCA and look at why you are having higher number of mosaics. Maybe suddenly you have some construction going on and suddenly you have higher aneuploidy and mosaic cell lines. So mosaic cells. So yes, if you do have higher mosaics, and yes, the best labs are not having high level of mosaics. Even our work with the Bloom group, we had mosaics which were far less than 5%. Even with the centers we are doing at Corion, very few mosaics, less than 3%. But if you do have higher mosaics, please reach out to help with your genetic lab or to your to any person, Dr. Deepak or us, because it is about collecting data from the PGT, for PGTA, and we need to know what are the real life consequences of doing PGTA, especially
And
for
at the same
smaller
time, it's
labs.
also exciting to see that Dr. Devika's lab, which we had a discussion in the previous meeting, do in-house PGTA. They have their own setup, whereas Dr. Krishna's lab OSS does PGTA outside, and the data is very comparable. So that's also heartening to know that all of those who want to start PGTA need not have a lab in-house. You can still do transportation, and that's a very successful model as well. So both the models work, both the models give nearly. So I was looking at the data, and the data is very comparable between the two groups. Coming from two independent parts of the country, working on completely independent protocols, and yet the outcomes are comparable. So I think it's giving a lot of confidence to see data from this country, and I think we are running late. We should move to the next presentation,
Yes.
and we'll leave more for discussion in the panel.
Please, yes.
Let's hear Fiona.
Okay, so it is my absolute pleasure to welcome Dr. Fiona D'Souza. She is a senior geneticist and scientific director of Anderson Diagnostics, and she is a dear friend of mine. We have had many hours of genetic discussions, and we would love to hear her speak about how to select a genetic laboratory, a very important topic. Can everyone mute themselves, please, before she starts? Please mute yourself.
Okay, that's silence. Great. Thank you, Dr. Sayali, for that introduction. And today I'm here to talk about how to choose the right genetics lab for your PGTs. Okay, a quick disclaimer is that this is a purely academic discussion. I do work for a genetics laboratory, and in this presentation in no way favors the company that I work for. And we would like to straightforward discuss what are the criteria while selecting any genetics lab. Okay, while making the choice for a genetics lab, the most important factors include evaluation of technical expertise, verification, and their validation protocol, their reporting structure, and as well as regulatory documentation and compliances. So when we look at technical expertise, you can always ask the laboratory to give you details about the genetics team. How are the people who are going to analyze your data and, of course, process the samples? You have molecular geneticists, and you also have genetic counselors on board. And one of the previous discussions we also had is genetic counselors who work with IVF centers, with PGTs especially, should have an in-depth knowledge of fertility, and then this has to be evaluated, of course, by a clinician. The validation protocol for most laboratories is pretty standard. It is done with when we first purchase instrument for PGT. Right now, the most commonly used equipment is next generation sequencer. There is a set of standard human genome that is uploaded into the system, and then that is followed by validations for several other applications of NGS, and PGT is one of them. So due to the difficulty in getting embryo biopsy samples, very few people do validate on embryo biopsy samples. So most of the validation is done on samples with known karyotype and then taken forward. The reporting structure is different from different laboratories, so you should always ask them for a sample report so that you can go through it. Is it clear? Is it defining all their reporting criteria, and are guidelines followed? Now, for most of us, we do follow ASHRAE guidelines because they are the main entity here. You can also go through ASM guidelines for the same. Regulatory submission includes compliances and certifications ranging from government-related regulations for PGT, because this falls under gender selection criteria as well as the validation certificates of the laboratory. Now, while judging a PGT lab for its quality, there are a few KPIs that we need to keep in mind. First thing, what is the equipment used? So from the inception of PGT, there are several different applications that can be done on several different equipment. Right now, the most commonly used is NGS, and it is by far a robust system, and it is designed for handling very low concentration and very low amount of DNA that we get, because this is a sample, probably one of the very few samples that are used in genetics which have only maximum 5 to 6 cells involved. Validation protocol, every lab has their own, and they will explain to you if you ask for it. And what are the limitations of the test? The limitations of the test have to be clearly listed in the genetic report to make sure that we are not missing out on any critical information that has to be relayed to the patient. The internal quality control system is also required. It's part of every lab. And we also participate in external quality control assurance programs, which is most of them are based out of country. The training of the people who carry out these tests usually is done mainly by PhDs who have a clear understanding of molecular biology and PGTs. And you need to get an idea how specimens are logged in their lab, how are they moving into the lab, and how are they being processed. The test results and reporting criteria is also different from each lab, and then you can have an idea how they are filed. One of the main accreditations we require for the PGT lab is, of course, ISO. Now, the most commonly known ISO is 9001. This has variable scopes, but what is most important for genetic laboratories is what we call ISO 15189. This basically regulates molecular genetic testing, and it is also given by NABL of India. The NABL certificate of the genetics laboratory, it has multiple factors that are assessed for, and it is important to understand that the molecular testing should be included into the scope of NABL while you're reviewing NABL certificates of genetics lab. Another accreditation which is most important is the licensing part of the laboratory, and this is mainly done by PCP entity, and you need to have a copy of the Form B of the genetics lab and also share your own Form B of PCP entity to the genetics lab. This usually happens when you sign a contract with the laboratory, and please ensure that the genetics lab has permissions mainly for molecular studies and chromosomal studies, because this is what is mainly taken care of during the time of PG. So coming to the external quality assessment programs, GenQuar is one of the most common QAs, external QAs that we do. And this usually happens once a year. They have samples, embryo biopsy samples of known karyotyping, and this is sent to the genetics lab. We have time to process it. And GenQuar assesses this in two different stages. First thing is the matching of the results, and second is evaluation of the report. So they do incorporate ASHRAE guidelines and make sure that all the information that is needed is there in the report, and it passes the minimum requirement for PGT. The second most important and the hardest accreditation to get is the CAP accreditation. This is College of American Pathologists, and this process is pretty long. Most of the labs do not acquire it in their first 2 to 3 years of work. This takes about a year to complete the entire review process. It is extremely rigorous and it controls every process and reporting structure. And this is reviewed every 6 months. So the lab submits all their data every 6 months of how the workflow is working. And this is now present with most of the genetics lab, but however, it is not mandatory in India, but it is mandatory outside the country. Coming to the validation protocol. Now, there are two factors, of course, to a PGT. One is the genetics lab and second is the IVF center. So when the IVF center chooses to start a PGT program, definitely the lab needs to be validated. This is a process of not verifying the structure of the IVF center. It is to verify that embryo biopsy can be done in a clean and controlled environment, that there are no mislabels or loss of any samples. Then also to make sure that there are no external DNA contamination which can interfere or make the results of the PGT void. And this is mainly done when the lab begins its PGT program. The second thing is the embryologist validation. Now, we have discussed this extensively and we have guidelines coming up on this. And every new embryologist who is planning start PGT needs to undergo embryologist validation. This requires a minimum of 75 to 100 biopsies or then proceed for the validation. That means before you send the samples to the genetics lab for validation program, the embryologist needs to have minimum 75 to 100 embryo biopsies experience before this is done. And it is extremely important to assess embryonic survival post biopsy and to assess phase 2 survival. Also, the next important factor is the whole genome amplification and also the concentration of DNA in the negative control. What happens if you get DNA in a negative control? It basically means that a negative control is a sample which does not have embryo biopsy in it. So if there is DNA detected in a negative control, it means that there is external contamination that has happened. This technically means the results that are generated out of the embryo biopsy are not accurate, are not descriptive of the embryo, and have some external DNA. The challenge with PGT is the amplification protocol is so strong, it will amplify every remnant of DNA there is in the sample. So if you have been careless during the washing process or any other sample has come into it, it really makes it impossible for the lab to know what is the source. Second thing is what we call a dry run. So dry run is usually what we prefer when you're switching between the providers. If you are sticking to a particular lab, it's fine. So when you're changing between service providers, always ask for a dry run. What it does is it helps you understand how the second genetic company works. It helps you understand if the kit is working fine, are there any difficulties, how is the labeling process, how is the transport process, and what is the reporting timeline. This will give you enough confidence to proceed when you change service providers. So when it comes to platforms of NGS, we have two main next generation sequencing providing companies. Usually the most commonly found is Thermo Fisher's Aneuploidy system. And they have multiple versions of this. And then of course you have Illumina. This is another NGS machine. And of course they have again multiple variants of this. Now, the type of machine of these companies basically means its scalability. So more expensive equipments, larger equipments to help us run more samples. That's the only difference. So if I go for a lower version or higher version of the equipment, it doesn't really alter the quality of the PGT. And the manufacturer stated resolutions are at 10 mega base space, 10 MB. This is the standard resolution for most NGS providers. And while looking at the performance of both these companies, they perform equally well for the application of PGT. And it can detect mosaicism down to 20% in any given sample. So there are a few critical points we need to evaluate while looking at the laboratory. First and foremost is how the laboratory manages whole genome amplification failure response. This is one of the most critical points for us, and it is also a part of evaluating how the embryologist is working and how the laboratory is working. So finding a solution will help us resolve future problems, and this has to be addressed on case-to-case basis and should be taken care immediately. So there are a few points of time when the whole genome amplification can fail. Either at the laboratory during the tubing, the biopsy cells get stuck to the strip of pipette and have not been delivered into the tube. In this case, we will get total amplification failure. And second, whole genome amplification failure can also be due to insufficient amount of DNA. So in this case, you will not be able to generate a good quality NGS data, and therefore even that is whole genome amplification failure. So look at how the genetic laboratory is working. Are they helping you troubleshoot? And the WGA success rate should be preferably above 95%. That means that we accept a whole genome amplification failure rate in the range of 2 to 3% only, not more than that. And the company should be able to clearly tell you their reporting policies. This allows us to explain to the patient very clearly what we can and cannot do with this particular test. And what questions not to ask. Now, pregnancy rate is something which is complicated. It is multifactorial, and genetic labs cannot be held responsible for your pregnancy rates. But what you can do is, this is something that our company always does. If there is a PGT pregnancy that has been miscarried, we always ask the doctor or the client to send the sample back to us for a microarray analysis. So product of conception testing is a critical part of evaluating when your employed embryo transfer has resulted in a miscarriage. There are multiple reasons where a employed embryo transfer can miscarry, and that's a whole different topic altogether. But we have found that non-genetic causes also play a significant role when employed embryo transfers have failed. Next is the transport system. So most centers should have their transport systems optimized before offering the services. This involves multiple dry runs, dummy runs, simulated runs. The transport usually occurs either in dry ice. This maintains your sample stable for a minimum of 3 days at -80. And I have seen samples being very, very steady when dry ice is used for shipment. We have never faced an issue with that particular thing. And also you have something called pullback shipment, which handles the shipment at -20. And this has to be really carefully monitored when we are dealing with something. So we can't really control how transport companies work. So the genetics company needs to be sure that the samples are moving in the correct timeline, specimens are not lost, they are tracked timely, and the maximum time to deliver into any genetic lab, as far as I know, in this country, we have not faced more than 8 hours of delay. The maximum amount of tolerable delay is 72 hours. After that, we severely expect something to have gone wrong. And you should be intimated that the sample has been received and the processing has been finished. Once a sample reaches the genetics lab, it is first transferred into its barcoding facility and then transferred into -20 or -80 to stabilize. And whenever the samples are processing for whole genome amplification, it is done. So another to address is the stability of biopsy samples. These samples are pretty stable for about 3 to 6 months when stored at standard -20 degrees. One point that I would strongly like to recommend is review contracts very strongly. It is always essential that PGD center should have the agreement with the genetics lab that you're working with. This not only ensures that the quality of service that is committed to you orally during the discussion is delivered, but also covers you legally when conditions like mismatch or turnaround time or sample rejection criteria is changed from what you expect. So make sure that whatever discussions you have had go down in writing, and don't just ask the lawyers to review your third-party contracts. You being the clinician should review the contract before it goes to the lawyers to make sure that all the terms and conditions are according your acceptance. So the main important points to make an informed decisions with the genetics lab should be the credentials of the scientific team, because they are the most important and critical part of this entire process. How is the support system working? Do they have geneticists and genetic counselors on board? How is the patient support? What is their policy for whole genome amplification failure cases? Are they going to charge you? Which usually process is the most expensive part of the PGT, the whole genome amplification process. So most of the labs will charge you if the whole genome amplification also fails. And you should also clarify what is their policies for a repeat biopsy in case you choose to do so. Do they have follow-up test support in the sense post-pregnancy? If you're facing any complications, are they still being responsible to follow up with you, get you information? Are they clear in their communication? And of course, are able to answer all your questions regarding validation. The take-home points is mainly to focus on three main important criteria. One is the expertise. Second is how is the service of the center. And third most important thing is how the communication flows within the system of the genetics lab. Thank you so much.
Thank you so much, Dr. Fiona, for this wonderful lecture. And even though I'm hearing for it for the second time, I still feel like I would benefit from hearing this even more. And again, please, everybody, please kindly mute yourself. It really disturbs the speaker. And Dr. Deepak, do you have any questions in terms of the genetic lab?
I think I'll first let the audience ask questions and then
Yes.
I think because I've been poking my nose too much.
Absolutely. Yeah. The audience can ask some questions. We'll start the panel in 3 minutes. So can I ask one question? I'm sorry, I have this answer. So in terms of the genetic laboratory, Dr. Fiona, you mentioned the CAP accreditation and how that is beneficial in improving the quality of the program, the PGT services that you're offering. What kind of accreditations apart from that are available for PGT laboratories that we can use to evaluate the laboratory?
The main accreditation is, of course, ISO. And let me clarify one thing. The challenge with PGT is the only entity which provides us actual embryo biopsy samples to evaluate this process is GenQA. Now, GenQA has samples for this purpose. So every other accreditation that I spoke about, if it's NABL, if it's ISO, if it's even CAP, this is mainly controlling the process, the infrastructure to begin with, the process flow. And also, they do give us DNA samples. They don't give you embryo biopsy samples. So when you get a DNA sample and then we proceed with the amplification and the reporting, that's completely different. Handling embryo biopsy samples is different. Now, the biggest challenge, embryo biopsy samples are not easily available. And if I speak to my counterparts out of this country, they usually rely on IVF clinics to be able to donate their samples which they have already assessed with another genetics laboratory. Now, if you evaluate how PGT works, you should be able to reproduce the result at 98%. So any Euclid and Aneuploidy result is reproducible at 97 to 98%. And of course, mosaic embryos is a whole different category. The reproducibility is very low in such cases. It is around 65%. So I think we should also work towards developing a database of embryos, and the patient consent is a very critical part there to be in place. So this is the main limitation with the accreditation policy.
Okay, and you do believe that specifically Indian embryo, cells available for PGT laboratory validation basically would help versus the ones that you get from.
Yes, and this is the main reason you need to do at least a dry run with the laboratory. You need to know that the transport system is in place. They are able to amplify the samples, and you can also ask for another dry run also if you're not satisfied. So if the first sample run is working very fine, you need to have at least a minimum of 6 to 7 biopsies going in here. And if everything is amplified, it is well and good. You can also ask the concentration of DNA that the lab has achieved. Usually it is not proportional to the number because it's a fixed PCR reaction, but it should be minimum above 10 nanogram for us to be able to generate a clear, good quality NGS data. And if it is not meeting this criteria, you should ask for another dry run or reconsider your decision.
Okay. We look forward to working more in terms of
another thing I would like to discuss is there are no clear guidelines on how to set up a PGT laboratory. So most of us rely on known DNA concentrations and known DNA karyotypes, and then upload it into a system, and then the system learns as the number of samples increase. So if it's a new provider, definitely they will face this challenge. And honestly, we have so many genetic companies coming up. It doesn't mean that necessarily bad. Even we faced the same issue when we launched our company, and we were going against, we were up against standard companies from out of this country. So I think that we should be able to define those criteria, and that is something that we are working on. And what we were able to do is we had a lot of prenatal samples, so we had known karyotypes, cells, suspensions with us. So we were able to titrate with 3 cells, 5 cells, 8 cells, and then develop our system. And these were babies, we had live-born data for these babies because this was prenatal, right? So that way we were able to titrate the results better. But most genetics lab will depend upon standard cell lines with the known karyotype and then start with their amplification.
Okay.
Dr. Sheetal has a question.
My one question to Dr. Fiona, how to decrease the cost of PGTA? Because many a times when we offer to the patients, because of the cost, they draw back. So how we can decrease the cost per PGTA for the patient?
That's extremely challenging. What I will tell you internally is, even if the genetic lab, every year increases their number if they're good enough, and that will significantly reduce the cost. So usually when we began also, we had expensive pricing, but given the fact that most of these reagents are imported into the country, the prices are increasing per year. But the good thing is, because of the competition in India, the prices offered by genetic companies is reducing. Even if they're out from outside this country, it is reducing, and right now it is becoming affordable. But what I will tell you is, PGTA and SR is something that is becoming fairly affordable now, but PGTM is still very expensive, and this is because it's a customized test, and there is nothing we can do about it. I mean, even when we import a kit, it is extremely expensive, and it takes time also. It has a turnaround time of 3 to 5 weeks for us to import the test, so we need to be prepared in time. That is why the pre-PGT workup helps us to develop the assay in time and get it imported. They're not made in India these days.
Okay,
Sheetal.
thank you.
Yeah, so Fiona, that was a very nice lecture. I just have one question. I wanted to know your experience with the PGTA biopsied samples vis-a-vis their abortion reports, in case you have any of them.
We don't really have data on the abortion rates regarding PGTA.
Not abortion rate, as is the final report.
Yes.
The report.
What data I do have is I have a list of 5 cases where a transfer was attempted and they have miscarried or ended up with ultrasound anomalies, because this is something that we track, and the doctors usually call back to us and said this was a PGT embryo. So these cases, the deletions that were found, which were responsible for the ultrasound anomalies, were below the resolution of the test. For example, one of the case had a 200 kb deletion, which is beyond the resolution. The resolution is 10 MB. This fetus had multiple anomalies, and I have had 3 cases where the fetus miscarried and the microarray did come to us in time, and we had completely euploid karyotype. So then we went back, we evaluated non-genetic causes. One was a immunological cause, 2 were placental insufficiencies. So we should pay attention to why an euploid embryo transfer has failed. And usually our way of working is you can always send us the sample of the terminated fetus and then we can reevaluate. But the embryo data is also available with us. We can always go back and look at it. But the analysis does not really change anything. You have it stated. There are certain cases where you report sex chromosome aneuploidies, and that may not be mentioned, the condition may not be mentioned, but you can talk to us and then we can give you an information on what sex chromosome aneuploidy it is, because if it's a sex chromosome aneuploidy, we are able to deliver that information to you. And usually none of our clients have ever chosen to transfer such a sample.
Yeah. Right, thank you.
Another thing I would like to highlight is there are a couple of times I have received this question about mosaic embryos and a euploid embryo. So when there were a couple of doctors who wanted to transfer 2 embryos to the patient, one was euploid, one was mosaic, and these were the only 2 embryos available for transfer. So it's always recommended that we do not mix the 2, and euploid embryo transfer should not be mixed with a mosaic embryo transfer, because a mosaic embryo transfer requires invasive testing.
So, but now with the new data coming up regarding the mosaic and the concordance, and I mean, even the low mosaic embryos are almost as good as the euploid embryos. I think why not? Why can't we mix the mosaic as well as just to improve the pregnancy rate?
It is another risk factor, man. You have a euploid embryo which can completely go smoothly. I don't have to worry about the pregnancy outcome. I don't have to worry if it is going to miscarry. It reduces the anxiety to the patient as well, and more anxiety to the doctor. In fact, most of the doctors have more anxiety to the patient. But with a mosaic embryo,
another discussion altogether.
I would closely monitor it, so I would prefer keeping them separate.
Thank you so much.
We can move on to panel discussion now.
Yes, ma'am.
Dr. Sayali.
Excuse me, Dr. Fiona?
Hello.
Yes.
Hello.
Can you hear me, Dr. Fiona?
Yes, ma'am.
Yes.
Yeah, I'm Dr. Sangeeta. I'm a clinical geneticist at Jindal IVF Lab hospital. And I just wanted to have this question. You have mentioned that the resolution is 10 MB for all the NGS for PGT. But you have mentioned down also that 2.5 MB deletion. That is in PGT SR cases or in every case?
Usually it is PGT-SR cases, ma'am. We would have to increase the resolution to, we have increased it up to 5 MB, I mean down to 5 MB.
Okay.
But the challenge is the deeper you go into the resolution of PGT, the more reads it takes and the test becomes more expensive, first thing. Second thing, the amount of data noise also increases as you reduce the resolution of the test.
Yeah. Yeah.
So
But
the standard
it can
acceptable-
okay, it can resolute down to 2.5 MB. That is the maximum limit.
It depends on the protocol that has been used. If you're using an extremely high level sequencing, which we usually do for research setup, we can go a little deeper than that, but the sensitivity and specificity of the test will change. So
Okay,
right
sorry,
now, the sensitivity
But-
specificity is at 98%.
So can I interject and say that could we take the genetic discussion offline in terms of sorry to disturb because it's 6:36 already and we need to move on to the panel and please the geneticists, please if you could put your questions on the chat or on email. You have the email deepak@yahoo.com or drsayali@gmail.com. You can put the emails to us and we will forward it to the specific faculty. Okay, Dr. Fiona, thank you so much for the presentation and it's always lovely to have you. Let's move on to the panel. We have two wonderful moderators, Dr. Nisha Chumote and Dr. Manisha Vajpayee, very senior professionals in the industry. And Dr. Manisha Vajpayee is a clinical geneticist and a clinical embryologist, a winning combination. And Dr. Nisha Chumote is a very senior professional and embryologist in the field. So please welcome them, and they are here to do the panel of controversies to consensus on PGTA. Over to you, Nishad and Manisha.
Yeah, good evening, everyone. And it's been a wonderful session that's been going on. Have been enjoying all your talks. And let's move on to the panel discussion here. So what we are going to do today is going to talk about the controversies, basically. Just a moment.
Everybody, please mute yourself.
Right.
Mute yourself. Yeah.
So is Dr. Manisha there with me?
Yeah, I'm very much here, Nishad.
Right. All right. Wonderful. So yeah, good evening, everyone, ladies and gentlemen. We have had a wonderful session here. And let's begin with the panel discussion. I have my co-moderator, Dr. Manisha, with me, and we had a wonderful discussion yesterday itself to make this panel on controversies to consensus. That is where we are headed towards, because we had a wonderful discussion with Dr. Sayali and Dr. Deepak regarding this, that what we actually require, and the whole model of this panel discussion is not just asking questions, but getting your viewpoints, and then we channelize it into some proper consensus. So we are looking forward to your personal views and your personal experiences rather than what we have read in our texts and other academic books. So let's move on, and I'd like to introduce the first three panelists. Right, so we've got Dr. Ritu Prasad with us. So she's a gold medalist and a gynecologist and infertility specialist, consultant at Prasad Hospital at Rishikesh and at Dehradun. The next panelist with us is Dr. Meenu Vaish. I believe Dr. Meenu Vaish is there or not. She's also director and consultant at Meher Hospital, and welcome you, ma'am. The third panelist is Dr. Niharika Tyagi. I believe she is also here, hopefully. So she's also a gold medalist and head of fetal medicine and HRP at Zavitri Hospital and fellowship in fetal medicine. She is also an ISAR certified embryologist and executive member of ISPAT and joint treasurer of UPCOG of 2023. So these are the three panelists. Over to you, Manisha.
Yeah, Nishad. Actually, Dr. Niharika is not there with us today. She is busy with some case, so she might join us in some time. The next panelist is Dr. Ram Prakash. He is a very good friend and a very eminent embryologist. But unfortunately, he is again busy in some case, so he is not there. He'll be.
And I'm pretty sure he must be busy in some biopsy only.
I know he has got so many biopsies. So can I have the next slide?
Yeah.
So next, our next panelist is Dr. Akriti Gupta. She is MD Obs Gynae, and she has done her fellowship in reproductive medicine. And currently working as an infertility specialist at Sri Mahanta Indresh Hospital, Dehradun. In absence of these two panelists, can I request Dr. Sayali and Dr. Deepak to join us? Because yes, the panel is actually these guidelines. We all know they are very much needed for us, and it is their brainchild. So next, Dr. Sayali and Dr. Deepak, can we have you guys here with us?
Yes. Can you?
Yes,
So Dr.
very much
Sheetal's
so.
intro, can we have?
So Dr. Sheetal Jindal, she doesn't need any introduction. She is actually doing quite a lot. She's
here, yeah. That's okay. You can carry on with the panel. Yeah.
Okay. So first question, are you taking up, Nishad?
You can start with the first one.
So very basic question. Does your lab...
Can I interject here?
Sure.
Sorry. I love to poke my nose everywhere.
We love
just
that
before we
you poke
begin,
your nose everywhere.
just before we begin the panel, I would just like to give a genesis of this entire document, as we discussed yesterday. That we had the first draft. So the idea that we started with this was in Fertility 2022, where we all discussed that we need to have India-specific best practice for PGT in this country, where we included PGT-A, PGT-M, PGT-SR, and even NIPGT. While the discussions that happened, we realized that NIPGT would require a completely different set of discussions. So that was dropped off from the main document, and now we have PGT-A, PGT-M, and PGT-SR. So this document, a primary document, was made by some of the SIG IFS applied genetics members, and this was presented at Fertility 2022. And based on the people who were present there, a debate was conducted, and we finally made the first draft of the document, which was discussed in the previous meeting, which happened sometimes in March. This document was then revised, and now we are presenting to you, everyone here in IFS Uttarakhand chapter, as well as again the SIG IFS applied genetics chapter. So these are some of the revised documents where we have come to some consensus already from the previous discussions that are there, but there were some places where the consensus were not yet met. So we are going to have more controversy discussions over here. What we seek is your opinion on these questions. It is not a textbook question or a textbook answer that we seek for. We seek for more practical opinions, because please remember that whatever you would say here would be the part of the document guideline. So you do not want a guideline which is not within the reach of the clinicians and the IVF labs in this country, but you don't want a guideline which is also too diluted that it doesn't make sense. So let's stick to this point that we need your opinion and your practical document regarding these questions. Nisha, please go ahead.
Right. That was wonderful, wonderfully put. And regarding what we actually want out of this panel is what actually Dr. Deepak is saying, that yes, it is all about the controversies that will lead to the consensus. So please create some controversies, and let us begin with the first question. And over to you, Manisha.
So the very basic question to start with: does your lab practice PGT? Yes, no, intended, but not started. Do not intended to. So may I start with Dr. Ritu Prasad? What is your status?
Yes, my status is C. Intend to, but not yet started. But I intend to start as early as possible, because it's becoming a need of time. And this PGT-A, especially for aneuploidies, as more patients are coming with advanced maternal ages and recurrent implantation failure cases. So I need to switch over to PGT-A as soon as possible. But the main effect is coming of the cost. Cost is coming, and many a times in Dehradun, this embryologist has to come to do this PGT-A So that also increases the cost. So that's why.
So what about you, Dr. Sheetal? We all know that you have established a very good genetic clinic. So I'm sure you are doing it, and you must have done quite a number of cases. Am I right, Sheetal?
Not really. Means we do PGT, but yes, I'm more inclined towards doing PGT-M, and yet a few cases of PGT-A and SR also we have done.
That is interesting to know. Why less of cases of PGT-A?
It is like, I mean, there are various reasons to it. First of all, the indication for doing PGT-A, I'm not very, practically, I'm not very convinced with that whether repeated implantation failure is something which has a genetic origin or not. So once something which is not having any genetic origin, why at all a genetic test should be done for that. So, so the indication which we put for PGT-A is like, repeated implantation failure. And how many repeated implantation failure cases in advanced maternal age are because of,
Aneuploidies.
Yeah.
Case which has direct implication to the genetic, because implantation failure repeated, though there might be some genetic cause.
So in spite of, if I take the discussion forward, the most important thing which I want to put is, in spite of doing so much of PGT-A, why the overall pregnancy rate in IVF is only 40 to 50%, why not high?
That is another discussion altogether.
I think we'll go to that question soon. So let us, there are lots of questions that we want to cover here. So I would suggest that, So
how about Dr. Meenu? Are you there? Dr. Vaishya, are you there?
Okay, I would like to also invite Dr. Reema Sarkar to join us, and you can also please join us and tell us what is your view on this. Does your lab practice pre-implantation genetic testing? Do you have Reema with us?
Hi, Nishad. Good evening.
Hi, it's wonderful to have you.
Thank you for having me in. So sorry, I'm barging in. Yeah, I'm very well. So I am Dr. Reema. I am also practicing in Dehradun. I thought I might as well put in my inputs as well. So I'm with Indira IVF, and yes, we've been doing pre-implantation genetic testing for quite some time. We did it for quite some time, and then we kind of moved over to NICS because of the simple reason, although in Indira the cost was really not an issue, but it really did not increase my or change my success rates or results all over. So we kind of moved on to NICS. Yeah, that's about it.
So Dr. Reema, was this, I'm sorry for barging in, was this a central decision or an individual center decision?
Individual decision. It was not a central decision. We were kind of left on our own discretion, and our lab was standardized, but I really, although mosaicism was also not very high, but it did not really give me so much of confidence. Even after PGT-A, people were failing for X, Y, or Z reasons, and the success rates were not increasing. It was just taking on a lot of time and, a lot of other reasons. So we moved on to NICS.
Thank you.
So if I would like to request to come.
Could we also ask Dr.
Can I request the rest of them to please mute, because there's a lot of disturbance.
Yes,
kindly mute yourself.
We also have Dr. Saroj Agrawal on the
oh, that is lovely.
So we would like her
right, it would be great to have you, Dr. Saroj with us. Yeah.
Hi, Dr. Saroj. Dr. Saroj, are you there?
Okay,
kindly mute all.
Okay, please, could you mute all?
So that we can lead
Okay, we've got Dr. Meenu Vaishya. Please, so please, can you tell us? Do you practice pre-implantation?
Hello, good evening, everyone. I was in the OT, but I was listening everything. It is a great discussion, and as the question is, we most of the time we plan to do implantation genetics testing, but in our lab that is done by the embryologist only. So The problem is there that most of the time, when we do the, hello?
Yeah, we can hear you, Dr. Meena. Go ahead.
Yeah.
Please go ahead.
Most of the time, what number of cases these days we are getting the higher age group patients. So that is definitely a right method these days.
Something for both of you.
Yeah. So
All right. Yeah.
definitely it is a good way, and we have to go ahead to all these things. But lot of hassles and lot of problems do come. We do, our embryologists do PGTA.
Right. I think something's stuck.
We can move to next
Yeah,
question.
okay, ma'am. Right, quickly. So this was the scenario that especially the IFS guidelines that were to be decided. So the survey was, I believe, lots of people, lots of us were a part of this, and a lot of work has gone through this. So we found that there is out of 244 responses, you'll see that around 77%. Maybe can somebody mute yourself? There's too much of disturbance. Right. Thank you very much. Right. So this was the scenario. 77% said yes. So that's a wonderful thing. And around 11% intend to do it. It is only 10% who didn't want to do. So let us move on with the questions fast. And there are a lot of questions. So I would request all of you to be very crisp and brief, and so that we can have bigger discussions on the later part of the panel discussion. Right. So do you practice PGTA? We have mentioned that. Do you prefer PGTA or non-invasive? So state your reason. Would you prefer a biopsy or a non-invasive PGT? Just your views, and in one line, if you can just tell. I'll start with Dr. Akriti this time.
Hello, hi. Hi, Nishad. Hi, how are you?
Wonderful.
Hi, Dr. Sayali. Hi, Dr. Deepak. Hi, Dr. Manisha. And thank you, Dr. Deepak, for this wonderful opportunity.
Hi, Dr.
I'm really sorry.
So lovely.
Hi. You might hear a background noise of my daughter. I'm really sorry for that. So the thing is, yeah, I wanted to, support Dr. Ritu and Dr. Rima on the fact that, yeah, cost is a very big issue for the PGTA biopsies. And yeah, I have never practiced PGTA as such, but yeah, non-invasive, I am practicing. And the only issue was cost and the additional cost of laser, the embryologist being trained for that was adding up to it. So I think I have also found NIPGT a better option for advanced maternal age and for people who have a couple who have RIS.
Yeah.
So I go with non-invasive PGT.
Perfect.
We will have to speed it up.
Right. Can I have Dr.
Prasad, anybody is there? Come in. How about you, Dr. Sheetal? Are you there?
Hello.
No experience
Can I
with non-invasive. No experience.
Lot of disturbance.
Okay, everybody mute themselves, please. Sorry for being
Only the panelists and
Can
moderators
the admin mute everybody, and only the panelists can unmute themselves?
First mute all, I think.
Yeah,
yes,
can the admin mute
been
everybody?
muted.
First mute, centrally mute all, and then we'll.
Okay, all of you have been muted. Unmute yourself if you're on the panel.
Yeah, only the panels, please unmute yourself.
Hi, Nishad. Can I speak on NICS?
Yes, please go ahead.
So we moved on to NICS. However, I do have my 2 cents here also. So a lot of mosaicism here for obvious reasons, because the test is so. So again, it is risk benefit analysis, or what is in the end the test is bringing down to the table. So in the end, a lot of mosaicism in NICS also, although it became a little easier. So I'm not very happy with NICS as well.
Okay.
I have my reservations there also.
Fine, so, we'll go to that later.
That's a fantastic input, and we will definitely take that in account in the guidelines. Honest one, yes, right. and the NICS themselves have so many limitations. So if you want my answer, it is there in the survey. I was the first person to fill the survey because I created it with Dr. Deepak.
So no, definitely biopsy. But may I suggest that we ask one person only for the question and then move on, because there's so
Right,
many
right. We can do that. Yeah, sure. So yeah, so obviously the survey did say that testing is done with almost 81% people saying yes, and that is what we are looking for. The next is, yeah, Dr. Manisha would like to take this question.
So again, we have already actually discussed this question, so we can escape because we have shortage of time. Already shown reservations about PGTA. But I really would like to ask, given an opportunity, would you like to do PGTA for all? Those who are inclined to do PGTA? Dr. Prasad or Dr. Vaishya or Akriti?
Yes.
No, we will not do for every. We have to find the indication. Most of the time we do when there is a RPL, when there is genetic disease, when there is a family history, only we go for it. And age is another factor we go for. Otherwise,
so Dr. Meenu, what kind of family history? That's very interesting point.
it's very important. When there is a family history of any thalassemia, there is a family any family history of genetic disorders. So we have to go for it.
For
Right, but ma'am, we are talking here about
aneuploidy.
aneuploidy. So it's only PGTA that we are trying to discuss. We are trying to avoid SR and PGTM for this panel. So it's specific to A. So in such a scenario, where will you try to do PGTA? For what kind of patient?
In my scenario, if we are having a two implantation failure, 2 failures of ICSI cycles, we should offer a PGTA to the patient. Because many times advanced maternal age is coming a big factor for aneuploidies. So we should, if we are having the 2 cycle failures and rest all hysteroscopy and all are done and all are normal, and then also the results are not coming, so then we can offer first of all offer a PGTA to this patient and then move forward.
All right. So all the other panelists, do you agree with Dr. Ritu here that after 2, the third should be a PGTA?
Yes, I agree with Dr. Ritu. Absolutely.
All right. Lovely, lovely.
Sure.
Lovely.
Just can I interject here? Dr. Sheetal is the one who doesn't agree with it, I know. And I would really like to know her opinion, except for the fact that there is not enough data. Is there any personal experience that you would feel that it is not applicable, or you feel that you're still not convinced?
For out of the few cases which I have done, Dr. Deepak, so I remember, I can just quote my, few cases. I mean, we have a lot of data and there are a lot of biases in the data. So, so the incidence of abortion as the advanced maternal age is probably the only indication which I feel, yes, PGT could reduce the time to pregnancy. But from that perspective, advanced maternal age, usually the AMH, from the IVF perspective, the AMH decreases. So what I feel is that we do say that PGT reduces time to pregnancy, but where are the number of embryos which are there? Usually with advanced maternal age, we are not able to get those many number of embryos to biopsy and then to get a normal embryo and then to transfer and then get a result. So this whole exercise, becomes an added expense rather than, yes, in cases where, we have a good reserve and yes, you have a lot of embryos in advanced maternal age to choose from, where probably, maybe a euploid embryo can, reduce the time to pregnancy. But if we say that, yes, it is said that obviously a genetically normal embryo would improve the implantation rate, but would that actually give a higher pregnancy rate? I mean, I'm not very sure of that.
I'm completely convinced with that argument.
Only thing is, yes, we should be very able to categorically pinpoint, yes, the genetic reasons are the ones which are, responsible for, for not giving the pregnancy. Yes, in those cases, PGTA can definitely be applied, but it is very difficult to pinpoint as to, yes, these are the specific reasons where, and, it is very difficult to find such data. So, I mean, you might as well transfer in C rather than doing a PGTA. It's very, very simple. That's all.
In my view, a male factor also plays a very important role in aneuploidies. Male factor also.
So do you think that in such a case, DFI plays a role and that should be done? Do you feel that?
That's
both ways, both edges of the sword we should look after.
But I would like to ask, what would be the minimum number of embryos you would like to have to be sure about the biopsy procedure? Minimum number of embryos you need before going.
Five.
I think we will have that discussion in some time.
Okay.
Right. So let's move on to the next question.
In the guidelines till now, we had an answer of at least 2
Mhm.
that
Yeah.
had come from the 2 meetings that we have had, but 5 is a very interesting answer. We have had very varied answers from the service. So please
What are the severe
Right.
male factor
I'll
in
read it to show that.
severe male factors you would like to do PGTA for? Like severe male factors, what are those factors?
Morphologically
Morphologically.
abnormal.
Abnormal and OAT, oligoacetic.
Severe OATs, apart from morphology, is also very much important. If we are seeing on the slides, strain slide, double-headed and heads abnormal, and that may be the main cause of this recurrent implantation failure. So we should look on that factor also.
And one more thing I really wanted to know.
I'm not sure. Can I ask something over here? So,
Yeah.
Dr. Deepak, this is for you. Does severe male factor infertility increases the incidence of segmental, abnormalities in the?
Sure. So as because we know that most men with severe male factor infertility.
Dr. Deepak, your voice got cut.
Are you there? Yeah.
Dr. Deepak, Sayali, would you like to take up this?
Yeah, I'm here. I'm definitely here. But I think Dr. Deepak, it was
hello.
Like the climate movie, like he suddenly disappeared.
All right. So we'll continue with that question when we have them, because we have got a lot of questions. So I would like to run through them, and we have a less amount of time.
Yes.
Okay. No, so but
Right.
in terms of indications, Dr. Deepak, we would really like to spend like at least a couple of minutes. But indications is something we are struggling with. Even in the guidelines, they're so varied. Please mute yourself, everybody. All right. So basically, in terms of indications, we are still trying to enumerate all the indication for all the indications and even the data for the indications. So severe male factor infertility. Can everybody hear me? Because I can't hear.
Yeah. Go ahead.
Yeah.
Now
Okay.
we
Okay.
can
Sorry.
hear
So
you.
for severe male factor infertility, I think what Dr. Deepak wanted to probably say is there is definitely an increase in Y chromosome microdeletion, which is definitely under diagnosed in India. There's also an increase in sperm DFI, which is also underdiagnosed in India, and those have a role in rate of aneuploidy, which we already know of. So probably those are the indications. And severe male factor infertility combined with the male infertility.
Your voice is breaking. We can't hear you.
Oh, you can't hear me. Okay. I'm saying
No,
now.
we
Am I
got the gist
audible?
of it. So we got the gist of it. Don't worry about that.
Please continue with the.
Yeah.
Next.
Right. So so that is what we're talking about. Severe male factors. What are the tests that would you go in for in PGTA? That was what we're talking about basically. And what is the criteria for RIF and RF? That is a recurrent implantation failure and pregnancy loss. So what do you recommend in such patients? At what number of RIF and RPL would you decide to go in for PGTA? Can I start with? I think we can start with Rima this time.
She doesn't.
Okay, so
yeah.
No, I do it for RIF. Yes, more than actually, if we have implanted more than if both have been double embryo transfers and we have transferred it more than like twice, then I would like to go in for the third time. I would like to go in for PGTA.
Okay, Dr. Rima, here I would like to ask one more thing. Do you believe in your own transfers, or if a patient comes with a history of previous transfer failures, do you consider that as well?
Haha, very interesting. It of course depends upon where the transfer has been done. You kind of where you practice, you kind of sort of know places around you. So a standard lab, of course, we consider.
Okay. How about and what about recurrent pregnancy losses, Dr. Meenu, Dr. Sheetal, what is your minimum criteria about when will you call this case of RPL?
For RPL, I mean, I think it's better to keep 3 rather than 2, because there are true RPL is like something which is like beyond anyone. So why keep 2 and just add in, and you start doing PGTA, that becomes a little too much. And the second thing is in unexplained RPL. Yes, even I get frustrated when I get patients with 6 losses, 7 losses, and you have done everything and you have nothing to offer. Then probably I think PGTA is something which can help. But then with 2, I would definitely disagree. Just because it's 2 RPL, it's still a couple, and she's a fertile female. So so straight away IVF has no indication in recurrent pregnancy loss. So at the most, there has to be 3 losses, 3 or 4. I mean, we do not have a cutoff, and neither do we have data. But then straight away jumping to a PGTA, I mean, I would disagree very, very clearly.
No, Dr. Sheetal, I just want to interrupt that recurrent pregnancy loss after you have done IVF ICSI. If the patient after 2 transfers, you are
I think you're sticking to
implantation failure, ma'am.
Fertility issues, not natural pregnancy.
Yeah. I think after 2 transfers, if the pregnancy was positive and the cardiac activity was not coming, then definitely PGTA will be the answer.
So in that scenario, probably, we should be looking at the products of conception, and if they can give us, some idea. So, I mean, I was totally looking at a different sort of RPL. These are all questions I do not have answers to.
Ma'am, I would like to add something. Like Sheetal ma'am was telling absolutely correct. Like RPL, it's a different definition, and RIF is a different definition. But I think RIF it's always
extrapolation to. I mean, sorry. Okay, carry on, please.
You should start investigating, and I think for RPL there are questionable evidence. Like RCOG still states 3 or 2 or more, and there are revisions in the they write 3. So I think it should be given to the patient after a proper counseling, the option. If they can go ahead with it, good after 2. If not, I think you should always counsel that it's a choice you can make after 2 or after 3 pregnancy losses. I think if they are affordable, they can go ahead. It's always about affordability.
I am listening to everyone. Akriti, you are right. Sometimes patient, when it comes to the counseling to the patient, when it comes with the 1 RPL, they say, ma'am, do everything. We don't want anything in next pregnancy.
Yes,
you have
you're
to
right.
convince them that it is sporadic. Please
a very
wait,
valid point.
and next time you will be okay. Then
So
it
after
is
1 loss, ma'am, 1 loss is definitely, it is hard. It is disheartening for the patient, but then obviously the patient would say that, you do everything, ma'am. But then, I mean, we have to counsel the patient properly. I mean, 1 loss does not mean that, IVF failures happen. It is like, okay, it is important because it's an IVF and then an abortion has happened. So it's a little more concern. But then that doesn't mean that we, I mean, I would.
If you can see the survey here,
I would disagree
you can see the survey
straight away.
after 2 it is okay, but
And even the resolution of PGTA is like 10 MB, which is not that,
correct. Especially in RIF, when we have 2 good embryos and we find implantation failure, we are expecting implantation, everything is fine, then we have to, we should go for PGTA. In my opinion, I will like to go, because
quite a lot of information for you, quite a very and very interesting one. I hope you are enjoying that.
Yeah, we are
absolutely enjoying this.
Right. So I'll request all the panelists here that if you can see the survey here, that what are the indications you should recommend it. So obviously you've seen that in case of RIF, RVL, advanced maternal age, especially. So what the discussion that we are having, that it is mostly correlated to the advanced maternal age also, that you will find more implantation failures and pregnancy losses. So in that cases, you can actually decide. So that is what the consensus wants us to go, that you come to a consensus or a point where we can understand that what is a correlative or the factor that will determine us to come to decide whether it's 2, 3 or 5, whatever you want. So if you can answer in that manner, it will be very nice. So I believe we've answered, got the answer from few of us, few of the panelists. And reducing time to pregnancy is something that we actually think about in PGTA rather than actually increasing the implantation rates. So what is the view of all the panelists here, that does really PGTA increase your pregnancy rate, or is it just that it is reducing the time to pregnancy? Yeah, muted, Dr.
No, it does increase the implantation.
Dr. Deepak, please.
Okay.
Yeah, sorry, Dr. Sheetal, go ahead.
No, that's okay. It does improve the implantation rate. I mean, and that can finally increase the pregnancy rate. But reducing time to pregnancy, yes, it reduces the number of embryo transfers effectively. I mean, for cases in which, you have a choose. So PGT is just a tool to selection. So in case, now that doesn't mean that, we can just fit in the indications just because it's a tool to selection. That is how I look at it. I mean, go ahead, Dr. Deepak. I have nothing else.
I completely agree with Dr. Sheetal, but however, we must remember that when we talk about time to pregnancies, when we talk about, sorry, my internet is a bit of a problem today, so I have to close my video. When we look at a PGTA as a tool, it was never, although it was implemented in the clinical setup with the idea of improving pregnancy rates, but we must remember that the design of PGTA is to select your embryos. That you have a pool of embryos, and rather than looking by a enamina minamo or just going by the morphology, can we now select a genetically euploid embryo whose chance of implantation is higher? So in a sense, the heart of PGTA lies in actually a selection tool. I'm very disheartened to see that a lot of people do not look at PGTA as a improving to time to pregnancy, or whether time to pregnancy is even an indicator for a KPI. But looking at ESHRE now, which is moving to time to pregnancy as one of the key performance indicator for IVF clinic, we need to rethink on this. Having said that, I'm just going back to the previous debate, which is very important for us, is RPL and RIF. Whether, there is a long-standing infertility and there is one missed abortion. Should we not consider PGTA for that? Because should we wait for the woman to abort one more or two more times to offer her a PGTA, or should we say that no, that she has already suffered from infertility, that one IVF cycle is done, and that now that she has not, why can't she be offered? Because we know that a greater proportion of chromosomally aneuploid embryos do not tend to implant, or tend to implant but then just go away. So that's one thing which I wanted, and especially with advanced maternal age, I want one answer, especially from the panelists who are practicing here. This is that we know in the Indian context that women tend to enter menopause much earlier than the Caucasian or the European counterparts. And when we talk about advanced maternal age, and I was as a genetic practitioner and as a kid in genetics, advanced maternal age was 35. Now I see it's moved to 37. Are we doing the right thing for our women?
That, 37 onwards would, I think.
Why not 35? Our women tend to enter menopause by the age of 40, 42.
No, I mean, Dr. Deepak, you are raising such an important point, and let me also add that seminal paper that had come from the Nova India group and the Spanish group, where they had clearly shown that AMA, that the age of 35 in a Caucasian population is actually age of 33.4 in the Indian woman.
Absolutely.
In terms of AMH and in terms of ovarian reserve. So I think we should really reconsider the fact.
So that is the whole point, I think. I think, Dr. Sayali, that is what we are also thinking, that AMH also should be one of the markers where you can determine whether you should go in for PGTA or not. I mean, one of the variables, because that determines what is your ovarian reserve and also the quality of your oocyte.
No,
I want to say something.
Reserve. It has got no correlation with the quality of the oocyte. That is very, very clear.
Can I say something?
AMH is just a marker for ovarian reserve. Yes, the number of eggs in your ovaries are less, but it does not indicate the quality. We have enough data on that. AMH does not tell the quality of the oocyte.
But in practical experience, if we correlate AMH with a high maternal age,
one second. We are not talking about quality of. I'm sorry, Dr. Manisha, for cutting you. But Dr. Sheetal said we are talking about quality. We are not talking about the question was AMH. So let's stick to AMA.
Yes.
We are determining whether
this can be
talking about AMA, advanced maternal age, or AMH.
Both
we are talking about AMA be determined by what factors in the Indian population, because clearly in the Caucasian indicator, will not be working for the Indian population according to
No,
the previous
Sayali,
situation that we
the
have.
question is linked, I feel, because
Yeah.
when we say that the Indian women tend to advance more, but the question is that can we use AMH as an indicator of our impending menopause?
That's a
But
bit
what
iffy,
Dr.
no?
Sheetal is
It's a
also
bit iffy to
mentioning, what
use
Dr.
AMH.
Sheetal is also mentioning is that AMH is not an indicator of oocyte quality, because the whole idea of applying age as a cutoff is that we know that at later ages, the poor quality oocytes. And therefore, we should apply PGT. And I agree with Dr. Sheetal here that AMH is not a predictor of oocyte quality, it's just a predictor of oocyte number. So I'm not sure whether we should consider that.
I think
No.
age should be the age and AMH are totally independent. That is true.
Right.
Now that is true that with AMH, if you see the graph of the AMH, it peaks at the age of 23 years, and after that it is stable and then it falls down. So yes, with decreasing AMH, that female is likely to have an early menopause. But decreasing AMH does not mean that her quality of oocytes is bad. So I've had patients with an AMH of 0.2 and they have conceived with IUI. So it doesn't mean that any female at the age of 31, if she has an AMH of 0.2, she should be offered PGT. I totally disagree to that.
No, I think we are digressing.
Fine.
I think we
taken.
all
Point
agree
taken.
that AMH is not the point. Yeah.
Yes.
Definitely.
So
Yeah.
potentially
It is
we are not
definitely a
considering
criteria.
AMH as a criteria to offer PGTA. Perfect. That's a perfect consensus we have reached to, and thank you for that.
Lovely.
I
But
think we
yes,
should
age
move to the
I take this
next.
point that Indian women, sort of, you can say, like at 35, yes, this is my experience too, that they, the average age of menopause in India is 47 years. And for Caucasians, probably it is 50. So we all are always Western data driven. So for Indian female, that can be applied at the age of 35. But yes, we do not have the data, but we can reach that consensus. Yeah.
So does everybody agree with the age of 35? Because this is one cut which we needed since last 2 meetings that we have been having. I think, Dr. Nemo, what is your opinion on this? That should we consider age of 35 as a cutoff instead the European age of 37?
I think Dr. Minu is not there.
Yeah,
Dr.
I'm there.
Ritu?
So
Yes,
whereas the
Dr. Deepak,
PGT for Aneuploidy is concerned, that we should limit. Age is a very big factor for Aneuploidy. So we should
So what should be the
consider
cutoff
age.
that we should offer to our patients?
I think we should 35 should be the cutoff.
Okay. Dr. Ritu?
But we don't do, most of the time we do when 37, 38 in our practice. But I think 35 should be the cutoff.
So one thing more I can add.
35 should be the cutoff, but I think many of the time the patient when are coming from IVF in ICSI, they are at 35 years of age only when they come. Most of the 60% of the patient. So in my view, 37 should be the cutoff, because most of the patient are coming of 35 years of age of only
Why should
for
men
the
not
IVF
just walk
ICSI.
into the clinic at the age 35,
So-
not be offered PGTA? Why should we wait for her to age for 2 more years?
So I think, Dr. Deepak, I have just one more thing to add. At the age of 35, probably, if we take PGT as a tool to embryo selection, so at the age of 35, probably, she's on the verge of, either just going down and, there is no chance of her having a better, she will further deteriorate with respect to her ovarian reserve also. So if we want to apply PGTA, it should be at an appropriate age so that you can have some embryos to select probably and, give her, reduce the time to pregnancy, and the reducing time to pregnancy at the age of 35, would definitely help her.
So are we moving?
Probably
Are we
35
moving towards
should be
for age of
taken as a-
35? Are we moving towards for age of 35 PGTA
See,
for all?
can
Can you
be
say that?
recommended.
Yeah.
Can be recommended.
Hello.
I think Dr. Sheetal is there. Is anybody agreeing with Dr. Sheetal or would like to counter her for that?
Nishad,
That
I
is-
want to counter her. I want to
Yeah, yeah.
counter.
Okay.
Hello. So I have a point to make. Okay, fine. We are saying I agree with the study that Caucasian women and Asian women, there is a difference in ovarian aging and everything. So 35 makes very good sense. However, aren't we giving a lot of importance to PGTA? Has anyone really seen increase in overall success rates after PGTA came in? Other than the theoretical advantage that it does seem to provide, has it actually turned out practically into numbers also, that really we've seen a dramatic increase in our success rates, or a decrease in miscarriage rates?
That is how PGTA started. I mean, that is how PGTA started.
It did, but it hasn't really turned
females.
out into numbers, ma'am. It might have appeared so beautiful, but it hasn't really given me at least those kind of wonderful results. And all over the world, it's really not turned out to as good a tool as it promises to be.
Okay, I think we are deviating from the discussion. I mean, we are not questioning PGTA. We are questioning whether PGTA should be applied at 35 or 37. Am I right?
Yeah, right. We are already doing PGTA, but once which year we need to talk
which
right
age?
now.
Yeah. So we will not. These two discussions would be totally separate, I would say.
Right.
Yes. We will definitely pick these points up. We are making a note of these. But let's finish by 7:30, please.
Okay.
Yes, definitely. We got a lot of questions. I think we should move on to the next question. There's every question is like a 1-hour debate, so I'm sorry to say, but we'll have to cut down on the time. Manisha, please take the next question.
So next, can I have the next slide, Nisha?
Yeah, it's already there.
In your clinic, who explains the need of PGTA to the patient? Is it a clinician or embryologist, or do you have geneticist or genetic counselor in your lab? So Dr. Akriti, what is your opinion? How you are doing it, or how you are intended to do it?
I do it myself. I don't have genetist attached to me neither. My embryologist is that much, trained enough to explain. So it's only me, and then I hand over, have a conversation on phone with the Anderson labs. I have a, communication with Dr. D'Souza, so Fiona, and then we both go ahead.
So how about you, Dr. Jindal? In your lab, how you are practicing? Who is explaining to the patient the need of the?
I think for PGTA, usually as clinicians, but for PGTM, usually these patients need to be worked up. So now we have developed that idea of, it could be a genetic cause. And in case we feel that, previous history is suggestive of, then definitely we have a geneticist who is there to advise the patients on board. And that's how we proceed.
Dr. Saroj, I know you are doing quite a lot cases of PGTA. So in your clinic, how you are doing it? What is your...
Hi.
The embryologist.
Hi.
Lot of you, because I've seen your comment.
We are waiting. Yeah.
No, Manisha, we have a complete team of geneticists. So Deepanjana is attached to us full time. Any case which requires a PGTA, PGTM or SR, obviously Rajiv would be the first. I mean, the clinician would be the first one to kind of think that a PGTA, maybe, a PGTA, PGTM, SR is required. But the patient goes to the geneticist where she explains them completely whether it's their choice. She gives them her point to do or not to do. And then we leave it on the patient. If it's, if they feel, as everyone said, cost is a big factor. But then for people who are doing 3 IVFs, 4 IVFs, I feel doing one PGTA, at least for them, these kind of patients who are coming for repeated IVF, PGTA will give them a proper solution.
So you still believe in give them? You are quite pro.
I always believed in PGTA, and I think I will always believe in PGTA. For indicative cases, I think it's a beautiful tool, and we should not just kind of throw it away that way. It's a very beautiful tool when you have high DFI, male factor, and advanced maternal age. As the discussion was going on, if the AMH is good in advanced maternal age, we have got such beautiful blastocysts, and we have been able to do PGTA on a lot of advanced maternal age patients. So it's not that if it's advanced it's poor ovarian reserve is a big factor where we don't get lot number of blastocysts. So we have to cancel the PGTA cycle there. But in advanced maternal age, we have got good number of blastocysts, and we have been able to do PGTA and give them successful pregnancies also.
You have covered all the questions very briefly and very nicely, and a very different perspective we are getting. So what is the minimum number of embryos? Can you quickly tell us for PGTA your lab is opting for?
I would generally do at least 4 embryos, but then there have been cases where even 2 embryos we have done PGTA because the patient wanted they have had repeated cycles. Even ek bhi hoga to hum PGTA kara ke hi karenge. So I have done cases where even two or three we have sent for PGTA. Yes.
Okay, perfect.
So just one, sorry for interjecting again. Sayali, please make a note. Our next speaker is going to be Saroj. She will talk about her data. She will talk about her data.
I would second that.
Meeting.
I was genuinely going to say that I want Dr. Saroj and Dr. Raji's data for the next meeting, because they as we know, they have been doing for more than a decade. And they have been doing PGTA, and they have on so many indications, data on so many indications. I know Saroj is a dear friend, and I know that definitely their data would really help us. And
I'll try and compile all data, Sayali. Now,
there is nothing trying.
We
You have to do it.
I will get back to you with all the data.
I love that. I love that.
Yes.
Okay, anyways, just one point before we move ahead. Saroj, you said that in your center, you definitely involve a counselor before offering a PGTA as well. Now imagine a center like Dr. Akriti's or the ones which are in Uttarakhand, which may not even have access to a counselor. I'm getting worried that, when we start having in this country, I was just doing a survey with the BCGI, and we realized that only 300 counselors in this country, with only about 20 or 30 of them who are practicing infertility counseling. Deepanjana is a real exception, I would say. Should we start recommending having a counselor to general PGTA population of this country? And that actually gets me worried that how will Dr.
No, but Deepak,
let
me answer this. Whenever, whichever lab you are sending, let's say the lifestyle people had come to us, MedGenome people had come to us, everyone has a dedicated genetic counselor on their panel. So maybe it's just an online consult or something. It's not that difficult to get an online consult with a genetic counselor. Obviously, I don't know the cost factor or anything, but every lab is ready to give a genetic consult for your patient if you're going ahead for a PGTA.
Yes, I totally agree with Dr.
Akriti?
Yes, yes.
Okay.
I have
So you would consider
MedGenome
doing that.
person, Dr. Priyadarshini is also very good as a counselor, and she explains the patient very well, and they are very good at social media also. On WhatsApp also they reply to the patient directly can talk to them also. So that's a better, so that we can shift our work pressure, divide our work pressure.
Every lab I work with iGenomics, even iGenomics, any problem we have, that they are ready to talk to the patient also.
Talk to the patient also.
Yeah, there shouldn't be any problem, Deepak. I think we are just not kind of open to do PGTA. That's the reason why I feel there's so much problem.
Saroj, let me correct you here that as IFS, we have agreed that this country needs PGTA. And if you look at our respondents, nearly 70% are already doing PGTA, and about 12% actually want to do it. So now it's for this 12% which we are discussing, that, when they're at the fence, like Dr. Sheetal also is at the fence deciding to do or to not to do, how can we help them to be more confident about it?
Again, I want to bring one topic here, Deepak. Like when people say, we feel there's a technical difficulty with embryologists, so we are going with non-invasive PGT and everything. Has anyone realized even non-invasive PGT requires that much technical skill of an embryologist?
Exactly. I totally agree to you.
It's not like
Absolutely agree.
embryo biopsy is difficult. It is.
Ma'am, I think I'll add here. Dr. Saroj, I'll add to your point here because I'll contradict, because I know, like, we are here in a setup where cost is very much an issue, and if we have an in-house embryologist,
cost can be a factor. But when you say non-invasive,
I was perfectly fine with him because I could monitor myself. And I could see how I had a online consultation with the Anderson team, as in with Genesis speaking how to do it. Everything was given in a format. There was a pro forma. It is much easier, ma'am. You can't compare a invasive biopsy with a non-invasive.
I'm not saying it's much easier.
I will interject here. Sorry. I'll interject here.
I think
PGT versus PGTA, we will have a separate panel of discussion.
Yes. We are going to have multiple.
I would just like to add one thing over here. We are getting now weird requests. So people, a lot of times there are couples, who have 2 or 3 failures, and definitely they move to, with reserve poor and all that. So they move to donor eggs. And now people have started demanding that you do PGT on donor eggs. So this is another, area which is like very, very weird, what to do.
Oh, that has been around for very long, Dr. Sheetal. For about a decade, we have been doing PGT on donor eggs.
I mean, you know, indications out of indications.
Yeah, because it's actually a very good tool to select. Yeah.
I disagree. I don't think you need to do PGTA on donor eggs.
Yeah,
ma'am.
ma'am.
That's because the recipient
but I think we should
I think give 70 to 20% result. Most of the time at 55
now you have
years
excellent
age also.
results with donor eggs.
Cycles, I don't
IVF
think
per se can be a failure. It is not said, it is not like that IVF cannot be a failure.
OT cycles, I think very less. There are very good results with OT cycles.
No. Ma'am, can I just
comparative
here?
to
The patients
self-stimulation cycle with advanced maternal age, if you're taking the patient, and if advanced maternal age, OT cycles are saying there's a massive difference in the result. There's a great
I
difference
feel
in that result.
the patients are just worried about normal and abnormal embryos. That's the reason why even the recipients want an PGTA to be done to be sure that you are transferring a normal embryo. That's it, a euploid embryo. I think
There's
that's
a
the reason
psychology that you want,
if
you're
a
already
good
taking an egg,
receptive
so you want to
endometrium is
test it.
there,
That's the basic
in
idea.
OD cycle, if a good receptive endometrium is there, irrespective of the age, it gives a very good result. It gives a very good result in my personal experience, in my lab experience, I've seen.
Absolutely.
Yeah. All right. So can we move on to the next question? Yeah, we're already
Can we please wind up?
Yeah,
I'm okay not completing
because
the
we
panel
have
questions.
and we need to have 5 minutes to the company person, please.
Right. Okay, so we'll take one last question.
No, sorry. I'm okay not completing all the questions, but this is one question which I'm really wanting an answer to again, is donor cycles. You know, you are now having a donor cycle, which I completely agree that would give you a good pregnancy rate. But again, we must remember that PGTA is a good selection tool, which is not going to give you a patient just a chance of a pregnancy, but also have a pregnancy which is free of aneuploidies. Imagine a donor cycle done and then having a Down syndrome. Would you want your patients to go through that?
Right.
So I can give you one example, which is
and also if they are already spending so much, the time to pregnancy also decreases here. So yeah,
that's what I was coming to, just to be sure that the embryo is normal. There are a lot of recipients who get PGTA done on donor eggs also.
Yeah.
Yes, and actually on donor eggs, something that I also get worried, and this happened at a discussion in the BGCI meeting, the genetic counseling meeting, where IVF couple had a donor egg, and the first baby which turned out had a mitochondrial disorder. Yes. And they also had a second embryo transfer before the first baby was diagnosed. So, when we talk of donor eggs, we need to worry about a lot more things than just about making them pregnant with some young eggs. But whether these young eggs are healthy, are we giving them a healthy parenthood? Because now we are not just giving them parenthood, we are spending by the donors.
Dr. Deepak, the question arises, the patient should be genetically screened, the donor in this case, first of all.
Exactly.
So now so then that becomes the
you should start from
of
there.
the, so that is rather a better thing rather than doing a PGTA.
Yeah.
In case you turn up with some disorder and some genetic mutation or something in the screening, then definitely I think PGTA would have better indication.
Yeah.
So just screening of the donors is probably something which which should get incorporated in the
screening of donor. You can do is not a foolproof. You know that, Dr. Sheetal, and patients are not fully convinced that at the time of karyotyping and all those tests, while doing all these tests, we miss out quite a lot of information,
Dr. Sheetal, that will talk about inherited conditions like mitochondrial disorders and karyotypic abnormalities like translocation carriers. But still, that does not guarantee that all the embryos which are transferred are genetically euploid. We know that things like Down syndrome, not just conceive, also live. So I think we need this as a good point, and thank you for bringing this up. I think we can take the last question.
Yeah, I believe so. So we'll take this last question. Dr. Manisha, can you take this one?
So what pre-workup genetic test do you do for your patient before doing PGTA? Again, we are coming to the same question. So before PGTA, what would you like to do for your patient? Dr. Saroj, how you are doing it? Are you doing any screening for patients? I really want to know.
Yes.
So what is that? Karyotyping for both the partners, female partner.
Karyotyping for both the partners, and if it's a male factor, for sure we are doing Y chromosome microdeletions. And if a normal DFI, if it's a male factor, we always want to do a DFI to be on the safer side. So DFI would also be the test. Yes.
Okay. So DFI could be an indication if it is a very poor DFI. So you will go for a PGTA.
Yes.
Wonderful.
So is it like, first of all, you go for DFI and then go for Y micro deletion and then you go in for the third part?
No,
PGTA.
Once the karyotype is done, as I said, all the consults are done by the geneticist. She decides whether we need to go for that patient for a Y micro deletion or not. Then only we go for it. Otherwise, it's not like for every patient we are doing a Y chromosome micro deletion. No.
There are indications.
It's only male factor. In that also, if there's anything wrong with the karyotyping and the DFI, then we go for a Y micro deletion. Otherwise, no.
You can do it.
All right. And what is your view on Fragile X? Would you go in for the female for Fragile X syndrome testing?
Definitely for.
You're asking me, Nisha?
No, please.
Yeah.
Anybody
Please.
can.
And then Dr. Sheetal, you can continue after that, please. Yeah, Saroj, you can answer.
Patient, Fragile X, especially with the reference of POF patient, premature ovarian. In those scenarios, would you like to do that?
With premature ovarian failure, would you go in for that?
One, fragile eggs I have seen don't always give good blastocyst. So half the time the PGTA cycle gets cancelled as it is. So there's a very, very few cases where I have seen maybe good blastocyst. Otherwise, a day 3 freeze for fragile eggs, I feel, is better than taking them to a blastocyst.
We're talking about a Fragile X syndrome, not the eggs.
So definitely
sorry, I couldn't hear you only, Nisha. Yeah,
okay,
sorry.
it's okay. No worries.
Yeah.
It's fine. There's too much of disturbance anyways. Yeah. Dr. Sheetal, you can talk about this.
Just for POI, definitely Fragile X is something which we should, be looking at. That is very, very definite. So females are usually carriers and they would not manifest with the disease, and the males would be, that is
absolutely
the problem with Fragile X, and this must be done. There is no doubt about that. Yeah.
So, Dr. Deepak, are you satisfied or you want more opinion?
I believe Dr. Deepak has a lot to say on this.
Yeah, I think it's a good discussion that we are having whether Fragile X screening is necessary, because yes, in cases of POI, we should, because then that qualifies for PGT-M also, considering that there's now a high chance of giving a baby with another form of abnormality, which otherwise is not. But in the non-POI cases, should we recommend PGTA as a routine, like in case of, we are doing it in case of azoospermia or oligospermia, the Y chromosome microdeletion? Should we consider it in non-POI cases or only in recommended cases of POIs? Anybody would want to comment?
Sorry, I didn't hear. Sorry, couldn't hear.
Dr. Sheetal, the question is, you said that in POI cases, we should do a Fragile X, but if it's not a POI case, should we do a Fragile X first before offering PGTA, or it's just only for POIs?
I think for POI, this is the incidence of Fragile X, it is like 1 in, and it is more commonly seen with POI. So why, we would like to do it for every...
Because, POI is a progressive condition. You would never know which woman would go to a POI way early. Right. Now, here is a couple who is young, who is at the age of, let's say, 27, 28. She might go into POI, and you will recognize clinically a POI at the age of 30, let's say, 30, 32.
So wouldn't that be a decreased ovarian reserve? So the definition of...
Yes. So then should we wait for a POI to happen, or all those with a low AMH
see, poor
at very
ovarian
early
response and poor ovarian reserve is different from premature ovarian insufficiency.
Absolutely. So POI, because it's going to be diagnosed only when she goes for a POI, right? Clinically.
Right.
So she has an early menopause. So now, let us say a young couple who has come to you, who is for a fertility treatment, and you don't know whether she is going to go to a POI or not. So the question
So the definition of POI applies after the age of 40. That is the definition which is there.
Okay. So now a young woman, because Fragile X is an indicator for, Fragile X screening is an indicator for the males who will carry that chromosome will
Right.
develop into the Fragile X kind of a condition.
Syndrome. Yeah.
Yes, Fragile X syndrome. So should we screen all the infertile women for Fragile X as well? Or you think
No.
the incidence is too low to be worried about?
No. So it should not. So we have to differentiate between decreased ovarian reserve vis-a-vis the POI. These two are totally different.
All right.
And usually with a poor ovarian reserve, so we always have to see the FSH levels also. So they have to be above 40 for a female to be labeled as POI. And for a poor ovarian reserve, the definition doesn't hold true. It is like a decreased ovarian reserve or at whatever age. So at the age of 20, if a female is having an FSH of 40 and an AMH of less than 0.5, I think is the cutoff. So then that is something which is called as premature ovarian insufficiency. I think, I understand your question, but maybe I'm not able to give you a very satisfactory answer. But I would definitely get back to you on this. And it is very, very clear that POI and poor ovarian reserve are two different
POI
things.
are different conditions.
Yeah.
All right. So I believe with
I'm
that,
just mixing up with the, but then these two are totally different. Yes.
All right. Perfect.
All right. So with that, I think we will come to the end of this panel, and because we are obviously short of time, but I believe we had a wonderful discussion. I wish we had a lot of time to discuss. There are wonderful questions, and we could have spared more time to each and every topic. But unfortunately, this is the case. But I'd like to thank all my panelists here for a wonderful discussion, going in depth on certain topics and really creating controversies so we can come to consensus. And with that, I'd like to thank Dr. Deepak and Dr. Sayali for, on behalf of Dr. Manisha also, I believe I can say that thank you very much for this opportunity, and my wonderful panelists for making it really lively, enlightening, fast, and interesting. Thank you very much.
Thank you all for being here.
Thanks for our two moderators.
Yeah,
Dr. and Dr. Manisha Vajpayee, both very enthusiastic and dynamic.
Very fantastic.
Yeah.
And I think, Dr. Deepak, it's a wonderful attempt on your part to create these guidelines. PGTA is here to stay, but in case if we are able to get more clarity on as to where to apply it, that would be very, very helpful.
Actually, so with this point of view, started this discussion, we were pretty sure that every question is going to be debatable, but we have to take up this because if we want to formulate guidelines, we need to hear the opinions actually. So thank you.
We can have a lot of more experienced, senior people than us over this discussion, and that could be of. I'm not saying. We are all the younger generation except for Dr. Sarojan. I'm not aware of everyone. But then probably for more discussions on PGT.
Super young. Well, all seniors are already here, Dr. Sheetal.
I'm so sorry. I end up putting,
It's completely all right. But thank you, Deepak and Sayali. I felt
due respect to everyone,
this survey was very, very necessary. Because there's so much PGTA bashing all the time going on. I think people need to know the positives of it also. The PGT cannot be for all. That's not the right way to go for it. But then just bashing it and people saying that PGTA is worthless, hopeless is really not done kind of.
All over the world, internationally, all over the world, there are certain groups that are towards PGA, pro and against, but you have enough data to convince people otherwise. It is very important to see what is the actual indication, and because of the because everybody's so scared of being bashed in public in conferences, people don't actually come up and say they're doing enough PGTA, whereas
I had so many cases, Sayali, where if I've sent 10 embryos, all the embryos were abnormal. So for patients like this, if IVF cycles are not working, at least you have an answer for it, why it's not working, right? Just doing repeated IVF cycles doesn't help. At least you have an answer that you have all abnormal, sir. That's right. So maybe you should go for a donor egg or a donor sperm, and somewhere something changes, right? It's not happening with your gametes,
I completely agree with Saroja because then you have to face the music. Yeah.
Abnormal embryos, would you like to transfer any of them? Or would you
I don't think anybody would like to transfer aneuploid, no?
Not
I really
unemployed.
know it.
I'm talking about mosaic, like
Mosaic.
Okay,
Yeah,
yeah,
mosaic.
mosaic is the question.
mosaic.
But I think the mosaic question can be handled in a separate webinar.
Yes.
Yes.
let's
So
all
I think
enjoy
let's have a
Saturday night
PGTA
now.
for mosaic embryos,
Yeah.
controversies to consent.
Actually, we had a question, 3-4
That
questions
would
regarding
be-
mosaic, but we are falling short of time.
And
But
please have
I
a non-invasive PGTA panel also.
Yes,
I want to
yes,
get into that.
yes, we'll get into everything. And we are very glad to have you here. We have seen you for a long time, actually.
Seriously. And when I saw the comments, when I saw her comments, I thought I should take her in.
Okay, so I'm sorry to cut everybody off because it's also a meeting of friends when we talk in embryology and in genetics. But we would like to wind up. Dr. Deepak, is it okay if I let the company person present for 5 minutes and just wind it up?
Yes, perfect.
All right. Okay. So Dr. Vineet Arora is here from Nutri IVF. Dr. Vineet, please. Yes. Hi.
Yeah, good evening all. Good evening all. It's one wonderful presentation, wonderful discussion. And, we will not take much of your time. Already it's been extended. So we want to play 2 videos of 2 minutes each. So I just want, Nazreen, please, can you share the videos?
Hi, is there a problem? Nazreen?
Yeah, it's coming, Nazreen?
Yes, yes.
Okay.
No, we can't see the video. Dr. Vinny?
Yeah, I'm there.
Can we? I think there's some issue. Can we?
Okay, Nazreen, are you okay? Nazreen, are you trying?
Yes, yes. 1 second, 1 second.
Okay. Just we'll wait for another 1 minute. If it's not happening, we'll see.
A massive 6-fold.
Can you see the screen?
Yes, everything is fine. You can just go ahead.
Redefining treatment paradigms in IVF. There is a critical role of gut microbiome in sperm DNA fragmentation. Gut dysbiosis can lead to sperm DNA fragmentation via 3 pathways. Number 1, gut dysbiosis leads to increased pro-inflammatory cytokines, leading to endothelial injury, which can disrupt gut-testis barrier, leading to increased ROS, causing sperm DNA fragmentation. Number 2 is where gut dysbiosis leads to increased endotoxins, which reduces steroid hormone synthesis in Leydig cells, which further leads to reduction in pituitary and luteinizing hormone synthesis, ultimately leading to azoospermia. The final one confirms that gut dysbiosis can lead to increased insulin resistance, leading to impaired metabolism of retinol and vitamin A, further causing imbalanced microbiome in the semen and the testis. The imbalanced microbiome can lead to sperm chromatin damage, causing increased ROS and ultimately causing sperm DNA fragmentation. Doctor, clinical trials confirm the role of specific strains of fertibiotics in restoring gut-testis axis in sperm DNA fragmentation. Studies have confirmed a massive 6-fold increase in sperm motility and significant reduction in intracellular hydrogen peroxide levels and sperm DNA fragmentation after 8 to 12 weeks of treatment. Doctor, a recent article published in International Journal of Reproductive Medicine confirms specific strains of fertibiotics improved sperm concentration, motility, morphology, and a significant reduction in sperm DNA fragmentation. Doctor, this study was a triple-blinded randomized clinical trial on 56 men with idiopathic male infertility. Launching the first microbiome treatment to address the root cause of sperm DNA fragmentation, Androbiome. Each capsule contains Lactobacillus rhamnosus, Lactobacillus casei, Lactobacillus bulgaricus, Lactobacillus acidophilus, Bifidobacterium breve, Bifidobacterium longum, Streptococcus thermophilus with fructooligosaccharides. Doctor, Androbiome tightens the leaky gut and reduces pro-inflammatory cytokines. Androbiome corrects insulin resistance, improves vitamin A metabolism, reduces chromatin damage, and reactive oxygen species. Androbiome creates homeostasis in the semen and testicular microbiome. Androbiome significantly reduces sperm DNA fragmentation. Doctor, please prescribe Androbiome specific fertibiotic in all your ART procedures like IUI, IVF, and ICSI to males with sperm DNA fragmentation. Androbiome improves both physical parameters of the sperm and intrinsic sperm DNA fragmentation. Dose 1 capsule BID for 3 months.
Thank you, Nazreen. Nazreen, can we play the second one, Preg Biome?
Yes.
Okay, just 2 more minutes.
Okay, just a moment, please.
Yeah.
Biome can impair the process of embryo implantation. Endometrial dysbiosis can lead to repeated implantation failure.
Sorry, is it playing?
Yes, it is playing.
Okay.
In women undergoing in vitro fertilization. Not only this, microbiome's composition of the female reproductive tract has been associated with pathological shifts affecting reproductive process, fertilization, implantation, maintenance of pregnancy, and microbial colonization of the newborn. Doctor, a comparative study of histology, microbial cultures, hysteroscopy, and microbiology published in 2018 has shown the eubiotic and dysbiotic conditions of endometrial biopsies. The green slice shows the percentage of eubiotics microbiome in the endometrium. The remainder represents the population of dysbiotic conditions. The pro-inflammatory cytokines ILS, IL-6, and ILB were significantly higher in the dysbiosis group. Doctor, gut endometrial axis and endometrial dysbiosis can lead to implantation failure. Endometrial dysbiosis can lead to increased pro-inflammatory cytokines, which reduce IGF-1 levels, leading to increased endometrial perforation and decreased endometrial receptivity. This causes implantation failure and recurrent pregnancy loss. Doctor, IGF-1 levels are considered to be one of the most important factors in endometrial receptivity. Studies confirm that specific fertibiotic strains create homeostasis of the gut endometrial axis. Clinical data suggests that a preserved microbiome balance can correct cytokine network. This increases IGF-1 production in the endometrium. IGF-1 has proliferative, differentiative, and metabolic effects. This causes endometrial differentiation, and IGF-1 is considered as a vital marker for embryo quality and implantation. Launching PregBiome, the first microbiome to enhance endometrial receptivity and implantation in ART.
Each capsule contains 30 billion CFU of fertibiotic blend Lactobacillus gasseri, Lactobacillus jenseni, Lactobacillus rhamnosus.
To all women undergoing ART, please prescribe PregBiome. PregBiome is vital for a receptive endometrium to facilitate implantation, pregnancy, delivery, and good health of the newborn. Dose 1 capsule twice daily for 3 months. Redefining treatment paradigms.
Thanks, Nazreen.
Yes, hello.
Thanks. Thanks. I'm sure that, after this presentation, you'll be having a lot of questions, and you also want to study and read the clinical data which is present. So please, this is my number. I'm Dr. Vineet, co-founder and business head of Northern India. So please, in case if you have any questions, any query, and you need this clinical data, please just message me, or you can click the picture of this slide so that my number could be saved, or you can email, or you can message me just one line so that, we can be in touch with you, and we can send you the data. We can personally even visit the clinic, and we can always discuss. Just for the immediate interactions, please click on this slide. Please save this slide, and you can just message me just one line, and we'll be able to send you the data. Sure. Thanks a lot. Thank you very much. Thank you very much for this wonderful presentation.
If you can stop sharing the screen.
Post this meeting. Thanks.
Thank you.
Thank you, Dr. Sayali. Thank you, one and all who were here. It was wonderful listening to you all and having a nice talk with you all. And it was great. It was nice, though I do not know much about the topic. It was eye-opener for me too.
It's actually, I'm sorry.
Yeah, please.
The thing is that I'm too excited because we also want to announce that we are running the first microbiome webinar on 3rd of June, 2023.
Oh, wow. Okay.
And we will be talking about the role of microbiome and women's health.
Okay.
And that will be happening on 3rd June, 2023. And we will be continuing with the association, and we will be learning much more about the effect of the gut microbiome on the reproductive tissues in women's health. All right. Save your date of 3rd June, and that was the announcement from my side. And thank you so much for sticking around with us for PGT. And
thank you so much. It's my pleasure. It's our pleasure. It's our pleasure.
Thanks a lot. Thank you.
Thank you. So we'll end the session with this, and thanks a lot, Dr. Sayali.
Yeah, one second.
Dr. Deepak too.
Yes, Dr. Deepak, could you want the last word?
Thank you so much. On the behalf of SIG IFS Applied Genetics, we thank the company for providing us with this wonderful platform. And I thank all attendees here who have spent their evening with us and helping us to prepare this draft guidelines. And it's me, Dr. Sheetal, and Dr. Sayali, who would like to sign off from here by thanking everyone, each and everyone, for participating and giving us this wonderful discussion, and looking forward for you in the next meeting, which is also going to be on the microbiome. And we continue with our discussions on PGT, NIPGT, and its applications in India. Thank you, everyone. Have a nice evening.
Thank you so much. Thank you.
Thank you.
All right. Thank you, everybody.
Thank you.
Good night.
Night.
Thank you.